once you have unmuted yourself, made your point, etc., if that person would then continue to switch off their mic so that the meeting can run smoothly. All right. On that note, I'd like to welcome you all and to check if we have any apologies. Ms. Adams, have you received any apologies?
Madam Chair, we haven't received any apologies. Yep.
Thank you very much. We'd then like to welcome all the members of this committee. We'd similarly like to welcome the Premier and the Provincial Director General, the Provincial Minister of Health, the Head of the Western Cape Department of Health, as well as officials in attendance. The meeting will run as follows. We will have a presentation from the Premier's office as well as the Health Department, and thereafter we will have a session of questions and answers from the members of the committee. So without further ado, if I could hand over then to the Premier. Oh, hang on, I see, is there a point of order? There's nothing on the chat line. Honourable Dugmore, you have a point of order? Honourable Dugmore, please raise your point of order. Okay, you seem to have changed your mind. No point of order is being raised. We will then proceed to start with the presentation. If the presentation could be pulled up so all of us can see it, and then we'll hand over to you, Mr. Premier. Welcome.
Thank you very much. Just checking, can you hear me?
Yes, we can hear you.
Yes, we can hear you. Great. I think just as a brief introduction, and obviously the presentation will be done by the DG as well as the HOD of Health, joint presentation. But perhaps before we start, I just want to say that it's just over a month that we've been in a declared disaster space, but it's probably a month and 2 weeks that we've been operating in, I want to call a sort of high alert, 7 days a week operation. So it's a month and 2 weeks ago that we started with the 24/7 of the JOC. We then started with our own PTM already stepping up into the disaster space, although it wasn't declared. We then had the declared disaster, and then since that day, we've been having 3 cabinets a week. And of course, all of the work streams, I'll take you through them from safety and security. This is the JOC as well as the joints. That's the police side. So it's the Prov joints and the NAC joints. They meet all the time. Generally, police and JOC have a formal meeting every morning at 8. But of course, they're operational 24/7. We've got strategic or strategy and planning. We've got health. Again, health. I really want to take my hat off to the team there. They obviously have their national meetings twice a day. And I noticed that specifically the National Minister and Minister Mbomba can come in here as well. But the National Minister also likes to call 2 or 3 other meetings a day. And we've had the honor of having him here in this last while in our cabinet as well, as he's gone to see the readiness across all provinces. We have the humanitarian and social work stream. We've got the economic work stream. There's the local government. And that's also where the job fits in, the local government and the disaster management cluster. We've got the infrastructure team. We've got the finance and institutional team. This is the governance component. And then we've got a communications arm. And of course, I want to say to those officials, just taking today as an example, we've had a 3.5-hour cabinet today just getting report backs on all of the streams. But just today, at least 2 min-mecs thus far that I know of that were called today and happened today or are happening today. The DG has just informed me that FOSAD meet this evening, and our officials are meeting from early in the morning, 6 o'clock onwards, and meeting until 9 and 10 and 11 o'clock at night, 7 days a week. It is an unbelievable feat, and we are right at the very beginning of this pandemic.
Mr. Premier,
so I really want to use this opportunity to thank them all for what they are doing. And of course, we're going.
I'm afraid I'm afraid to interrupt you, but we have a point of order from Honourable Dugmore.
Yes.
Honourable Dugmore, what is your point of order?
Chair, now my point of order is that on the meeting chat group, we were alerted to a situation where tested positive with one of the mobile clinics, and we were very appreciative when we got hold of the HOD late last night, and there was an intervention, but the person said they were going to be collected at the house where she still is in Khayelitsha. That was at 9 o'clock, and when I last checked, no one had actually been to the house of the person that tested positive. And
Honourable Dugmore, would you kindly raise this offline with the HOD?
Okay, should I just send a WhatsApp message?
I would suggest so, yes, please. Mr.
Okay,
Premier, please
I will
proceed.
send a WhatsApp message. I don't want to interrupt the Premier, but it is something that greatly concerns us.
Yes, please do contact the HOD offline. Thank you very much. So it can be resolved. Thank you, Mr. Premier. Please proceed.
Thank you very much. And so I want to say to all of those officials and raise it with this ad hoc committee, which is obviously the oversight, to say thank you very much. This is 24/7, 7 days a week, no matter what these meetings are happening. It is quite a phenomenal effort. But also to say that this is only the beginning, and I think yesterday you'll see in the presentation by Dr. Kluti and Minister Mbombo that the health department specifically, which is at the center of what we're dealing with, starts to talk about the modeling. We've seen the national modeling from Prof. Karim, and now obviously every province has got their own unique challenges and their own unique environment, where we really start to see what's going to come at us. I mean, we look at how many people at the moment are either being housed in quarantine sites or in isolation sites that we've made available. And of course, what we really are preparing for in this lockdown is how that is going to escalate into our hospital space, and you'll see that in the presentation. Obviously, moving towards when we are going to reach what we are estimating in our scenario is our peak of 80,000 positive cases tested and presented in 1 week at the peak. So at the moment, when we have accumulated in total just around about 1,000 cases, you will then see that we get in 1 week 80,000 cases. And of course, that is what we are preparing for. Everything that we are doing is preparing for that occasion, and that will tell us where we are going to be under pressure. And we will tell you, as the presentation said yesterday, we will tell you again today that the real pressure comes in when it gets to hospital beds, because most people will be able to see this through in their homes. But there are so many people that are going to be needing hospital beds, high care, and we've got to put extra space. We've got 1,000 shortfall of those beds, and we are frantically trying to get those extra hospital beds in place. And then, of course, the real concern for me is the 750 ICU beds that, after putting everything else in place, we are going to be short. And we've seen around the world what happens when you get to that stage. Choices have to be made. And we have to put that up front. At the moment, we've got 750 ICU beds short in the system in this province. And everything we are doing is to mitigate that risk. And if we don't want to get into that space of the 80,000, we've got to make sure that we mitigate even more. And that is the work that is happening every single day across the board in this province. But I think we'll pick that up on this from the structure, from the DG's presentation, but also from the health point of view. And then I presume, I mentioned all these different streams. I presume the ad hoc committee will then pick up. At the moment, it's obviously health front and center. Secondary will be nutrition and hunger. Then the third leg, which is the most pressing at the moment, which will obviously be the possible unrest that we've already seen raising its head here and there based on high levels of unemployment and not the ability to identify those who are desperately in need of nutrition and how we get that distributed to those specific people. So those are the three main focuses at the moment, but today obviously focusing on the first one, which is the central leg, which is health. And if I can then just hand over, I don't know if you want to have questions on that introduction, or just hand over and that the DG takes it from here, and then of course the Minister and the HOD of Health, and then maybe allocate the questions to the end.
Thank you very much, Mr. Premier. We'll leave the questions to the end of all the presentations. Thank you. DG, if you could proceed, please.
Thank you, Chair. I just want to check, can you hear me?
We can hear you loud and clear. Thank you.
Thank you very much, Chair. Good afternoon to all the members. What I'm going to try and present jointly between myself and Dr. Kuti, who's the head of the department at the Health Department, is actually our own response to dealing with the COVID crisis. And I want to put it up front, and I mean, we're all aware that obviously things happen quite quickly, and as Premier has indicated, we already started quite early with preparing for what is going to come at us. So what we've done from a structure perspective, we've obviously taken our cue partly from the regulations that's been issued by the National Minister of Cooperative Governance on the 25th of March. And obviously,
come and fetch you.
And then create.
Fantastic. So we're.
Can I continue?
Yes, Honourable Dugmore, if you'd please turn off your mic. DG, hopefully that will resolve the issue. Please proceed.
Thank you, Chair. So the first slide actually this deals with what have we done from our side from a coordination perspective, obviously taking our cue from the regulations that's been published. And as you are well aware that those regulations actually allowed for a national structure as well as a provincial command structure as well as a municipal command structure. So the Premier has already spoken to slide 1 in terms of the national structures and the NAT joints and the prof joints, etc. that's actually been formed, and also the issue that these structures had then to be duplicated, if one can use that word, at a provincial level. This slide effectively gives a clear demonstration of what the regulations wanted us to do. So you will see that there's a requirement for a politically led structure, obviously in the provincial space led by the Premier through the Corona Command Council. And then there's also an administrative structure led obviously through the PTM or the provincial top management, and all our structures obviously feeding into each other. So you will see that our provincial command structure feeds into the provincial command council, and obviously the information that we have also feeds right into national, and then also we are getting information on a daily basis from the provincial disaster operations center. I think it's important.
Sorry to interrupt. It seems that the person managing the presentation has not moved the slides forward.
It's now on slide number 3, Chair.
We can only see the first slide.
It is projecting. I don't know whether there's maybe an issue with the data stream coming through. Can you see slide 3, Chair?
No, we only see slide 1. Okay, perhaps what I'm going to do is I'll ask Mr. Matthews from our side if he can then share the document for all to see, and then he'll just go through the presentation as you're talking. Would that be in order?
Okay, Chair, I think that would be in order. What I will do is I will just indicate yes.
Right, we're on the same page now.
Okay, Chair, I just want to check with you. Are you controlling the slides?
Our procedural officer, yes,
Chair.
is now controlling the slides.
Chair, point of
Sorry,
order, please, Chair.
Chairperson, how do you get to see the slides? I can't actually see the slides at all. How do you get to see the slides?
Okay. Honourable Dagmar, I'll get somebody to phone you to assist you. There was also a point. Who else raised a point of order?
Chair, yeah, I've raised a point of order. Member Syed.
Syed, Honourable Syed, what's your point of order?
Chair, I don't want to disturb, but I've noticed one thing, that the live stream is not picking up on the legislature website. I've checked now while I've been on this thing, and quite a few journalists, they're also tweeting in this regard, indicating that it's not working. I just wanted to get a sense whether the media currently has access to this, and basically, is it working currently? Maybe with the technical team, because I mean, this is a very, very important input that the HOD is making here and that the Premier made. Yeah, thank you.
Ms. Adams, can you perhaps assist?
Thank you, Chair. I think there might be a bit of a technical issue. There are people who can access the YouTube video, and then there are some people who cannot. I think some of the techies are trying to figure that out right now.
Okay, could we place the correct link in the chat bar?
Okay, yeah, we can do that.
Then if you need, we can all use that link because I think that link is then working. I'm just checking it myself. Yep, the link. I'll post. I can post the link in the sidebar, or if Ms. Adams, if you would post the link in there, and then we'll assist Honourable Dagmar to be able to see the slides. I think on that note, can we then proceed? The link for the YouTube live feed of this meeting is now in the chat bar, which you can use and share. All right, I think, Mr. Matthews, can you put the presentation up again?
Is this the correct slide, Chair?
Slide 4.
Slide 4. Okay. Next one. That one.
No, we're just seeing a screen. You're sharing your screen, share the document. There we go. All right, we're back in business. Oh no, it's gone again. There we go. Right, thank you. DG, please proceed.
Thank you very much, Chair.
Please ask Honourable Dagmar if you could put your camera off. It helps for us to have a more stable connection. Thank you. Please proceed.
Thank you, Chair. So slide 3 in essence sets out the requirements of the legislation. But you will see, Chair, the point that I want to make is that that requirement only came out close to the end of March. So what we've done on slide 4, if you go to slide 4, you will see that as early as March already, this Cabinet took a decision and actually formed a committee of Cabinet to actually lead the Western Cape government response to COVID. So what happened from that stage is that there were daily meetings that happened. That subcommittee was chaired by the Minister of Finance and Economic Opportunities, obviously also assisted closely by the Minister of Local Government and Disaster Management, as well as the Premier. And we met daily with all the respective leads to actually get to know what is actually happening on the ground in terms of responding to COVID-19. In April, Cabinet then took a decision, and what we then did is we then formulated 9 particular clusters led by the respective HOD members, and I will take you through those clusters now. And we then had our first meeting on the 15th of April, where each of the clusters reported directly into Cabinet. We believe that by doing that, It created a much quicker decision-making process. We also wanted to obviously improve, I think, just the governance arrangements and obviously given the accountability arrangements of each of the departments within those streams, we believe that those streams have to be by the respective officers. The point I want to...
Can I switch it off? Okay, yeah. All right, it's off now.
Honourable Dugmore, please unmute.
What?
Thank you, DG. Honourable Dugmore, please mute your microphone. DG, please proceed.
So, Chair, I already spoke to bullet 3. So the meetings that are happening at the moment is that as cluster leads, we report directly into Cabinet now in relation to the 9 structures. And as Premier has indicated, there are 3 Cabinet meetings now per week. So Cabinet meets on a Monday, they meet on a Wednesday, and they meet on a Friday, and allowing all these cluster leads actually to report straight into the Cabinet structure. Chair, slide 5, which is the next slide, just deals with the 9 streams, and I think it's important to note that the health response will be covered by Dr. Kluter in the latter part of the presentation. Then we've got a particular stream dealing with humanitarian and social response. And maybe for your own information, because obviously this also goes back into your own parliamentary processes, that stream is led by the Head of Department for Cultural Affairs and Sport, obviously supported by the Department of Social Development, the Department of Education, as well as the Department of Agriculture and the Department of Human Settlements and Local Government. So you can see within that space, it's all the departments operating within the broader social space, and all those streams are then also politically led by each of the ministers that is responsible for those portfolios. And in essence, they deal with issues around quarantining, isolation, reintegration, nutrition, and hunger. Then local government and disaster management is led by the Department of Local Government. Obviously, Minister Bredell, as the minister responsible for local government as well as the disaster centre, he leads it from a cabinet perspective with Graham Paulser, the head of the department in that space. But there are also other departments playing a role within that, because obviously that's the first response to dealing with COVID matters. And in fact, it also includes ministers from the humanitarian and social stream. So that cluster in essence deals with the incidents management and response from the Disaster Management Centre out at Tygerberg Hospital. Then there's also an issue around coordinating, and then there is the issue around how to deal with waste from a municipal perspective, and then also the whole issue around bureau management, linking it back to the responsibilities of municipalities. Then important, Chair, there's also the business and economic response. That stream is led by Minister Mania as the minister responsible for economic opportunities, also supported by the ministers within our VIP2 space, if you can recall. So that's the Minister of Agriculture and also the Minister for Transport and Public Works. So those are the ministers responsible for the economy, and they're supported by the respective HODs. And in fact, what we deal with in that cluster is around business support, and then importantly is the recovery within the economy. And the important point there is also we're linking, with the national departments. Then there's safety and security response led by that department and Minister Fritz. And then there's the infrastructure response stream led by the Department of Public Works, also Robert McDonald, and they in the main deals with quarantine facilities, isolating facilities, reintegrating communities, and then the hospital facilities, given also the comment that the Premier has made around procurement and also construction. Then, Chair, finance, administration, and institutional support is important. On institutional support, we deal with obviously the institutional support relating to Western Cape government, because there are also other matters that we deal with outside of COVID. But importantly, we also, from an institutional support, need to make sure that our staff is safe, that our staff can deal with the response in relation to COVID, and that from a finance perspective, that we are able to deal with all the issues. So employee health and wellness, financial administration, financial management, leave, and the safety of our staff falls within that cluster. and then there's also a cluster dealing particularly with communication. So all the range of communication that you see going out from Western Cape government in relation to COVID-19, both external as well as internal, falls within that particular space. And you can see, Chair, that from a communication perspective, we believe that what we're doing at the moment is really to educate the community out there how to deal with COVID, but more importantly, how to prevent it. And then internal communication, I mean, it's my responsibility as the DG to make sure that our staff is kept up to, is actually kept informed about what we're doing from an institutional perspective. Then, Chair, if we approach COVID-19, there's also a stream that basically just lifts the head a little bit above the storm that needs to deal with the whole issue around strategic planning, strategic management, some of the modeling work outside of the core work that health is doing from a modeling perspective. And that's a team that needs to look at beyond the crisis. So how will this impact on our PSP? How will this impact on our APPs? And what is it that we need to do, once the crisis is over? Chair, if you look at slide 6, 7, 8, and 9, those slides just give you a little bit of insight into each of those streams, and I definitely do not plan to go through each of them. So just to recap, the humanitarian and social response on slide 6 deals with the issues around our call center, food, data, and then also the strategy. You can see from a call center perspective that we've now also upped the number of people to assist within that space. We've pulled in some additional resources, both from the Department of the Premier as well as the rest of government. And we also have, some people that are volunteering, particularly in that space. And I mean, if you go and look at some of the data, there were times that we received up to 10,000 calls per day, but we are responding to that space. If you look at slide 7, Chair, that just deals with local government and disaster management as well as safety and security, and gives you a little bit of insight as to what are some of the things that we're dealing with at the moment. I mean, we've assisted the foreign nationals with the repatriation to their different countries. As I've indicated, we're working closely with the municipalities. It's both the metro as well as some of the district municipalities, and the Premier is also pulling them into the Monday, Wednesday, and Friday cabinet meetings so that we can have direct access as to what is happening within the municipal space. At the bottom, safety and security, the provincial job structures, so the South African police are involved in that entire process. And if you go to slide 8, Chair, I have already spoken about the business and economic response as well as the infrastructure issues. You can see from a business environment, we're also looking at obviously procuring PPE, particularly for our health and frontline staff, and then also dealing with frequent engagements with agriculture, the retail, and other key stakeholders within the business environment. And infrastructure in the main at the moment deals with some of the quarantine and isolation facilities and all the issues within the broader transport and commuter space. Chair, I've already spoken about slide 9, and in essence, that just deals with the finance, communication, and strategy perspective. So, Chair, in summary, before I hand over to Dr. Klute, you can see that, I mean, what I've presented speaks to a coordinated approach by Western Cape government in relation to dealing with COVID. Externally, obviously, we are engaging, at the national perspective with the through FOSAT. Every Saturday for the last 3 Saturdays, myself and the Premier have attended virtually the Presidential Coordinating Council, where we actually provide input into that space. We're engaging with the National Health Department, also with the other DGs, because it's important that we not only have a Western Cape response, but that we make sure that we are all aligned as a country to deal with COVID-19 and fighting this pandemic with I think the main aim at all of this is to save as many lives as possible. That is what we're all working towards. And I mean, all the PT members as well as Cabinet is on the same page in relation to that. Chair, I'm going to hand over to Dr. Klute just to take us particularly to what we're doing within the health space. Keith?
Minister, I think Minister Mbongo should maybe just come in first, DG.
Thank you. Minister Mbombo, if you'd like to make some remarks. Minister Mbombo, do we have you on the line?
Was there?
Okay. We seem to have
Hello?
lost Minister. Ah, there you are.
Yes, I'm here. Yes, I'm here.
Please proceed.
Hello?
Thank you very much. Welcome.
Okay, all right, thank you. I was trying to unmute and then I went to the other set. Thank you. Dr. Keith Kruter is going to present, but I think the DG and the Premier made some of the introductory remarks in terms of that COVID response is not only about health, but also it encompasses the whole of the government and also the whole of society. And also from our perspective, we still have to strengthen the whole of the health system, not only in terms of the critical and acute care, which warrants, for example, the ICU and the ventilators. So I'm flagging this so that when the members ask questions, they mustn't only zoom on the aspect of the 10 or less than 10% of the people that will need to go for the ICU. The whole range from at the community level, the first level, primary health care, and also the aspects of the referral system, especially for those who do not have access, even currently, even prior the COVID. Because, for example, if now we are saying that, even if, for example, that we are saying that there's a positive case in Bito, when there is no hospital, at what extent that this person doesn't condition then they deteriorate because there is no access, but you are only focusing on how many beds in Knysna, how many ventilators in Knysna. But what about from the time that the person presents with even general symptoms, irritating symptoms like a sore throat, at what extent that person can be able to access health services? Hence, for us, the principles of the universal health coverage, the principles of community-oriented primary care, especially in the issues being driven by the community health workers. And also, when we talk about the health workers, we include the community health workers as well across, not only focusing on the availability of the ICU and all of those. And then you'll see at the end, when Doc is presenting the framework in terms of the strategy, when we remind people at the entry level, the issue of the community surveillance, because the availability of a service doesn't translate to the accessibility. And therefore, those people who might be there in the informal settlements or who even pre-COVID were not being able to access the services, and yet they are the vulnerable group. How do we ensure that the community health workers can go in terms of the surveillance and also in terms of going to those areas where we could be able to, in terms of the vigilance? And then at the end, again, it ends with a community engagement and also participation in terms of the reintegration of all those people back to their communities, because it talks about only the 14 days in terms of the quarantine. So the point that we're trying to highlight is that even post-COVID, we want to end up with a system that has been strengthened because we leverage with the resources potentially that we can receive at the time that we're fighting the COVID. Also, at the end of the COVID, we are also looking in terms of the system that can be able, that has been tested its resilience, so that any other, whether it's a second wave COVID or any other condition that impacts on us, at least we could be able to say that at least we do have some of these resources. To make an example of the 2010 World Cup, at the end, we've got the stadiums. Even if there's no World Cup, which we can be using them for something else. Same applies with us, is that we don't want a situation where we then end up having many of these field hospitals, which is okay, but we leave behind many of the people who do not have access, yet there are some facilities that are available. So I'll take the questions afterwards. Thank you.
Thank you. Thank you very much, Minister Mbombo. Dr. Klutty, are you in a position to continue with the presentation?
I am Member Wenger, but I have a disadvantage. It's not showing on the screen. I'm not sure who's controlling the slides.
Okay. Mr. Matthews, are you able to put the slides back on?
I'm sorry, Chairman, but this system is not working well. I have been off screen for a while and I couldn't see any slides, and I'm just waiting to see when they correct the system.
Okay. During Minister Mbombo's input, there were no slides that were being displayed. I'm asking Mr. Matthews if he can now share the presentation. I'll then just check that everybody can indeed see them. If you'll just bear with us for one moment. Mr. Matthews?
How come we can see it? Yeah. Got a better connection. Chair, we can see the slides from here, but from our side, but I mean, I'm not sure. Can anybody else see the slides?
No, we can't. Let me see if I can do it.
I only see the chairman and Cameron.
Good reason to get here. Good reason.
Bear with us one moment. Apologies.
Can you remember our first name? Can you remember our first name?
No.
Okay. Can everyone see it now?
Yes. Yes, we can.
Yes, yes, we can.
Okay. Is anyone unable to see it?
I see was Zaid and Chair Lady. I see you. I see Zaida Adams, and I see Cameron Double. That.
Okay. Honourable Marais, I'll ask IT to phone you to assist you. Is there anybody else that can't see the presentation?
You took it off again, Member.
Listen, I'm unable to see as well.
And then it went off again.
Okay. You should all be able to see health sector response.
No, it went off.
Okay.
Chief Whip?
Is that
Hello,
Minister
Chief
Mbombo?
Yes, can I suggest that you can just make it as an attachment in the chat, in the same chat, just make it as an attachment in the chat, because it becomes difficult for people. If you are using one device, it's become difficult if you have to go to their website outside. Yet, if you are still within, you can just in the chat, and then you just make it as an attachment so that people can be looking at it, opening themselves. I mean, as a file, attachment as a file in the chat group. It becomes easier if we cannot do it centrally.
Okay, I think that's a very helpful suggestion. So I will ask if the procedural officer will place the presentation in the chat, then each individual can open it and then follow while Dr. Klutty is presenting.
Okay. Thanks, Gigi. It's busy uploading. It's just a really big document, so it might take a while. But it is uploading.
Yes, we can see it.
If you could turn your camera off, please.
My apologies, Chair. 10 years, really.
What I'm going to suggest then is if all members click on the left-hand side, you'll see the word Teams. If you click on that, then you'll see in the middle block, it says at the top of the block, General, Posts, and then Files. If you click on Files, and you click on the meeting of the 22nd of April, you'll find a document repository. The first document is the presentation. So if you click on that document, it will open up. And there you have the presentation, and you can follow then manually as Dr. Klutty presents. Is everyone with me?
Yes, Chair.
Yes, Chairperson.
Okay, great. Okay, so we're all going to follow manually using the document repository. Thank you, Dr. Klutty. Are you able to present now?
I'm happy to present, Chairperson. Can everybody hear me?
Yeah.
Yes, we can hear you, and we're starting on slide number 10.
Okay, so it's a slide that's called Health Sector Response, Dr. K. So the next slide, it is the contents, and it talks about 3 parts of what I will be presenting. There is the current status of COVID epidemic in Western Cape, the predictions for the future of the epidemic and the likely resource requirements, and then the Western Cape strategy underpinning our response. Next slide. It is a slide that starts with the current status of the epidemic in Western Cape. And it starts with the slide, the next one, global and national context. Everybody on the slide? So just to make the point that there are lots of information around, the National Minister and Professor Abdul Karim briefed the nation about a week ago. The President is looking at all the things, and you heard last night, in all likelihood, he's going to pronounce on Thursday evening on what the way forward would be. The big thing for us in the health sector is that prevention measures such as cough etiquette, social distancing, hand hygiene, and the use of masks must be deepened. And we specifically say it is for high-risk areas and for vulnerable groups. We have to get this right in the next 10 days to be able to protect people beyond what might come after the lockdown. We also keep abreast of national and global development, so we're very much connected, as the Premier explained, to everything that's happening with the national team, with Minister Mkhize. Minister Mbombo, myself, are involved in many meetings with Minister Mkhize and all the other HODs and MECs across the country. And we're also connected to multiple other events. The next slide is a slide that says the 3 waves the Western Cape experienced so far. Member Wenger, can I just check, is everybody on that slide?
It seems to be. Is anybody having difficulty?
It's now gone. It was there.
Are they controlling it?
It's now gone, Chair. We had it before you asked.
Okay. All right. Let's bring it back up again. Okay, so we did ask members to open the document themselves and to follow with the document themselves. Okay, but the on the screen seems to be working again. So who was sharing the document? Zaida, can you try and share it again? Was that Mr. Powell?
Chairperson, I'll try from my side. Zaida she's getting back on again. She'll do it now.
Okay. Thank you, Ms. Kluter.
Okay.
If you could try share the correct slide.
Okay, there we go.
Just keep it like in that space. It's better.
There, that's that slide. Thank you. Thank
Right.
you very much.
Thank
So
you.
the 3 waves, which is the Western Cape experience so far. So what Professor Abdul Karim presented on national TV about a week ago is the slide to the left bottom. We said the country experience has been a blue wave, which is all the imported cases. A red wave is the cases associated with the imported cases. And imported cases, everybody that had international travel. And then the green wave, which he was saying was relatively low in the country, but the one on the left top is the Western Cape experience. That green wave has started taking off in terms of transmission. Just click the next slide, please. So on the right, you see our real data. You'll see the real data, not just the graphic data. You see the real data of our imported cases, which were blue. And you see the real cases of the red cases. And they all more or less come to very little transmission. And then you see the green cases, which was what we call local transmission cases. And what we've seen in the Western Cape since around about the 20th of March, where there were few green cases, all the way to the 19th of April and the 20th, which was 2 days ago, you'll see the gradual and quite steep increase of green cases. Next slide. And then what we talk about in the Western Cape is this issue about tackling bushfires. So what we see, you see a map of the Western Cape to the left. You see a map of the city of Cape Town above. And what we've seen in the last 2 weeks is specific clusters of cases. Specific cluster of cases. And these have been cases in factories. It's been in factories. It's been in supermarkets. It's been in prisons. It's been in police stations. It has been in multiple other places where people go to work. It's all places gathering where we've seen these specific clusters, and we call them bushfires. And those clusters are places where people work, but the same people that work there have to go back to the geographic area where they live. So if you were in a supermarket and you got it as a worker, you have to travel back to the area where you live. So everybody in that supermarket lives in different parts of the metro. So that is what we mean. That has been our experience over the last 2 weeks. And there's specific big clusters. For instance, in one factory, up to 70 cases. In one supermarket, more than 50 cases. And then there are smaller workplaces, but many across the areas that we are still getting some positive cases. Next slide. This is a little bit small, I hope members can see, but this is the data as of today. So the data that's about to be released, and the minister and the premier started there, we are over 1,000 cases. We have 1,068 cases as of 5 o'clock last night. And you will see that 856 of those cases were in the city of Cape Town and 159 in rural districts. If you look at what I just said on the line, the first column after the name of the sub-district, that's the imported cases. That was what I called the blue cases before. The second one is import associated, the second column. Those are the ones that was associated, that was the red ones. The one that we're looking at for the bushfires is the third column, which is called local transmission. And it's in that line that you can see at 721 local transmission cases, 98 of them are in the rural districts, and 614 are in the city of Cape Town. Let me go to the rural districts first. You will see that Witzenberg has got 34 of those 90 cases. So it's more than a third of all the cases that's local transmission is in Witzenberg alone. And if you look at Breede Valley has 13 of them. Now, if you take between Witzenberg and Breede Valley, that is almost 50% of all the cases in the rural districts is in those two areas. And we now have a slider. I'll come back to the data that we're making available over the weekend. If you go for the last 7 days, you will have seen a increase in cases in Breede Valley and in Witzenberg, and it's driven by 2 or 3 clusters in those specific areas. If you come back to the city of Cape Town, that's above the line, you then see that local transmission in Eastern is 72, Khayelitsha is 60, Klipfontein 60, Mitchell's Plain 60, Northern 56, Southern 79, 181, and then Western 166. Now, these are all the local transmitted cases. So across all the areas in the metro, those big clusters, factories, supermarkets, people that work in this place actually live across all the sub-districts in the metro. So we have seen rapid growth of local transmission cases in every one of the 8 sub-districts in the city of Cape Town. Next slide. This is just to tell you what we're doing in terms of testing. Because testing is one of the key interventions, the availability to be able to test people. So I'll start on the left top. That is to indicate to you that the green bars indicates what the private laboratories are testing, and the blue bar indicates what the public sector laboratories are testing. And you will see in the most recent time, more and more tests in the public sector laboratories as opposed to initially more tests in the private sector laboratory. In the last 2 or 3 days, you see a bit of an upswing in the private sector laboratories. That is because we have agreed with some of these big factories and supermarkets and retailers that they should take for their own workers, take some of that testing back into the private sector testing, that it doesn't overwhelm the public sector testing. So you'll see an upswing of the green bars because some factories have started testing via private sector laboratories. The graph to the top right that has 2 red arrows pointing to it, that means the one at the bottom is the number of tests we've done. So that's the blue line. Where the first red arrow is where we have started, the definition has been widened for people to be tested. Up to that point, you had to almost earn your test by saying you've been overseas or you've been in contact with somebody overseas. And that was around about, it was about 2 weeks ago, where we opened that definition. The NICD opened the definition. So from that point onwards, there was a little bit more testing done. But then also, we introduced community screening and testing as well. So because we are testing more people, that's the blue line going up, we also find the number of cases positive has become less. So we have much more negative cases now to find more cases, if that is understood by everybody. At the bottom, it just gives you a sense of all the testing that we've done to date. And you will see from the community screening and testing, that's the teams going out into the field. You see that 48,000 people have been screened in the metro and 32,000 has been screened in rural. And in the metro, 3,600 tests have been done and rural 140. So that is what we've been doing so far with the community screening and testing initiative in the field. Next slide. This is the daily total screenings. And it's just to give you an indication of how the screening has moved over a period of time towards to where we are now. And obviously today, which is the 22nd. So yesterday's data came in this morning. There's a slight increase again on the 22nd and the 23rd. The dip on the 17th was the Easter weekend when there was not screening done over the Easter weekend. Next slide. Next slide. Okay. And this is then the test. It's a similar picture of, you'll see that we peaked and that up to date, 3,801 tests have been done. In the Strandfontein camp, there's also been screening done for COVID. People screens. 62 were screened and tested. 14 results have been received. And all of those results in the Strandfontein camp was negative. So there is no COVID in the Strandfontein camp. Next slide. This is just a slide to give you outcome of the patients that we have to date. And what we're showing on the left-hand side is we say the people that have been admitted in hospital. Now, the majority of cases that have been admitted in hospital in the light blue bar has been in a general ward, not in an ICU. The yellow is the people that's been appointed into an ICU admission. And the bottom one is the people that have died. So what you see on the right-hand side on the top, this is just to make the case so far of all the cases we've seen, is that 88.7%, nearly 90% of cases that we know has not been in hospital. So 88.7 or 90% of people, when they get COVID, do not have to be in a hospital. They're well enough to be at home, and they're well enough to recover by themselves at home. 8.4% of people were in hospital, and only 2.9% have landed up in the ICU. The bar to the right, to the bottom, gives you an indication of the admissions in hospital and what has happened over the time. The green bar is for admissions in private hospitals, whereas the blue bars has been for admission into public sector hospitals. Next slide. This slide gives you the age distribution of all patients. So the left-hand side, that's all positive cases. That's the full 1,000 cases that we have to date. Of all the cases, it says that if you take the bar of, which is the yellow bar, it's yellow is for 60 to 79-year-olds, and blue on top is for 80 plus. So for all the cases we have, there is only 14% of all the cases between the age group 60 and 60 and above. But the moment you start saying admitting people to hospital, all of a sudden, the people that get admitted to hospital, 30% of them is 60 and above. If you then go into ICU, you find that 35% of people in the ICU is over 80. But you can see the big difference between in hospital and ICU in that people over 80 makes up 4% of admissions in the ICU. 4% of all admissions is over 80. But when you go to ICU, 12% of everybody landing up in the ICU is over 80. When you then go to died, you see that 44% of people are over the age of 60. And you see the big proportion, almost 20% of them are over the age of 80. What does this tell us? It tells us that the people that's most vulnerable and likely to be more ill than others are people that's older. But also at the bottom, you see that 70% of the people that dies in the last column also has other diseases. And when we say more than one or more comorbidities, it means they've had diabetes or hypertension or heart disease or chronic airways disease like emphysema or HIV or TB or a combination of them. So there's two things that we get from the slide. Is there are people, the elderly is more vulnerable for COVID and for more severe illness with worse outcomes. And then secondly, people that are ill because of other conditions are also more vulnerable. Next slide. So this is health workers. We take this extremely seriously. And this is a comparison of how many doctors so far has been positive. So we have 3 doctors in the public sector that's positive, 5 doctors in private sector. We have 4 nurses in the public sector that's positive, 12 nurses in the private sector that's positive. There is 13 other workers in the public sector that's become positive and 10 in the private sector. The next slide gives you the breakdown of the other. Those are 4 cleaners, 3 security guards, 3 people working in the lab, technician, 2 admin staff, 2 drivers, people that work in laundry, a pharmacist, a paramedic, occupational therapist, and one community health worker has also become positive. Next slide. Now, this is the slide where we've made a commitment yesterday, as that we will put all of this data that I just spoke to you about, a lot of the data, we're put into a granular format into the public domain. Our team is working very hard in creating a dashboard where people will be able to go into for updated information about what's happening and give the information so that the public has access to the information. Next slide. So the predictions for the future of the epidemic and the likely resource requirements. Next slide. So just to say that we are doing, there's a lot of technical work being done in South Africa. And actually there's a national consortium. I was very fortunate last night. I was sitting in on a meeting where the national consortium gave their feedback on modeling. And there's at least 3 modeling groups involved in that national consortium. And there's a whole lot of other technical experts from many institutions in the country working together into one broad issue about creating models so that we can plan scenarios for the future. There's a lot of uncertainty about the proportion of the population that will become infected. So there's big speculation about what proportion will be infected with or without interventions. The second one is the proportion expected to be totally asymptomatic. Now that's a big thing that's starting to come out. Even in our factories, we found some of that. In that we found some positive cases amongst people that didn't show any symptoms. And we're starting to quantify that. There's uncertainty of exactly how much that is. The international experience is also not very clear on that, of how many people that has COVID actually show no symptoms. And then the last one, as I showed you about the elderly, the slide about the people in hospital. It's uncertain how severe the clinical picture will be in people that have symptoms. I mean, our assumption is we're going to have no symptoms. You're actually not showing any sign of the illness. So you are, for all intents and purposes, completely well. If you start showing symptoms, how severe are you going to be? Are you going to need hospitals? Are you going to need an ICU? And are you at risk of death? The contextual variation between countries, we've learned from all the countries overseas, but the age structure of the populations are different. So if you compare us to Italy, or you compare us to China or to the USA, our age structure is slightly younger in this country. So you would expect, okay, maybe we are less at risk because we have younger people. But then if you go to our health system capacity might not be able to be the same as what it is in first world countries. Also, the level of comorbidity, so the level of number of people that actually has diabetes, hypertension, TB or HIV might be more here than it is in other areas. And then also this impact of social distancing, interventions like the lockdown, and whether we are going to be successful with social distancing and masks, what is that going to do to the patterns? Then population density and informal settlement is probably our biggest concern because there is no international best practice to learn from. We're the first country with significant numbers that is learning what will happen when you have infection in densely populated areas and informal settlements. And then on top of that, pre-existing socioeconomic vulnerability is another uncertain and unknown. So I'm putting all of this here to say that you need to read the scenario from a context that a lot of these things is not clear to us. So at any given time, we're saying, we look at the global experience, we draw from our own data, we are guided by the National Department, and we are guided by all the technical work in light of all these uncertainties. And then to the next slide, we then make a scenario. So this slide says the scenario with all of those that I've just mentioned. And it says at the bottom here, it's premised on an age-adjusted estimate for symptomatic patients. And as the Premier said yesterday in the release, according to this, at the peak, there will be 80,000 symptomatic people. But that it doesn't tell you how many people might be positive that's not symptomatic. It's only the ones symptomatic will be roughly 80,000. That translates into us being between 6,000 and 7,000 acute beds short if we have completely maximized all the bed capacity in this province between the public sector and the private sector. The yellow line is for general beds, and the darker blue line is for ICU. The graph to the right speaks to this, and that is that we are making a scenario. So actually our scenario is to the right-hand side, the flat, the lower one. But we're planning for a scenario that maybe it comes quicker and maybe it comes earlier, so that if something untoward happened, then we're not underprepared. That's the point of that slide. The next slide. It then takes both of these, and it says in the acute beds, where we're roughly going to be 1,000 short, we are planning for field hospitals to fill that gap. And I'll come back to the field hospitals later. But at the bottom part, where the ICU beds is going to be 750 short, the rate limiting step here is to find not just ventilators, but is to find enough equipped, skilled staff, which is ICU nurses and intensive care doctors, to be able to look after people in ICU. We can get some ventilators, we can get all the other things that goes with it, we can maximize our capacity with the private sector, and we will still be 750 beds short. Next slide. That is, sorry, if you can just go back one, please. There. We've created that little blip to the right. This is probably the most powerful case to make of why we must contain, follow up all these hotspots, and make sure that we do everything in our power to flatten the curve and break transmission. It's because we don't want that 750 to be a big peak. We want to be a manageable peak from an ICU care perspective. Next slide. So this is, just one back please, sorry. Okay, so in the Western Cape, our approach, and this is what Minister Mbombo was referring to you, is to say that our approach has got 4 distinct phases, put it that way. There's a phase of suppression and containment. That's all the blue things. And what we're in the middle of at this point in time is to drive as hard as we can with what lives in that blue thing. That is community prevention, it's screening and testing, it's hotspot identification and response, and it's isolation and quarantine. The next phase, which is the health system response, we are preparing for that now. It's the ability to triage and test in big numbers. It's the ability for the primary healthcare system to cope with COVID patients coming in and still to continue to do non-COVID care. It's the ability of acute hospitals to be able to absorb and admit COVID ill patients, but still maintain critical care and other serious illness for under non-COVID conditions. But also we're saying it is also an opportunity for us to strengthen our palliative care system, because at the peak, we expect more deaths than we would normally have in this situation. So it's a good thing to actually look at how we make dignified death one of part of our interventions. The next one is the adverse outcome, which is deaths, which in itself, at its peak, will respond into more burials and the ability and the system to cope to be able to deal with more burials. The last one is recovery and vigilance. So as I said to you already, actually out of all of this, we expect 99% of people to recover, because actually the people that's going to die is going to be about 1% of all cases. And many of the problems is because I'll explain to you a little bit later about how we're dealing with it now, and the exact case that member Dagmo is talking about. Cases like that of people sitting in Khayelitsha or being in informal settlements, having to be uprooted from their communities into isolation. Part of our big thing, if we do that in big numbers, is not just recovery, but is reintegration into society and dealing with the issues that what we've dealt with in that situation and the humanitarian support that goes with it. Next slide. This is the right-hand side is our comparison, and as I indicated yesterday in the press release, we had a lovely conversation with Professor Abdul Karim. And on the left-hand side, you will see this the phases that he made announcements on. And as a country, we all work in those 8 phases. So you can see that our 4 broad areas and the 8 phases, it's a seamless alignment, the stages it's there. And you see that the current focus is we are in stage 3 nationally from a lockdown perspective. We are doing surveillance and active case finding. We are doing hotspot mapping. We're doing the medical care, which we've expanded a little bit more into triage, PHC, acute hospital, palliative. And the death and aftermath is the death. And then the ongoing surveillance and recovery is what they've introduced is also the notion that you need to push the wave out until there is a vaccine, and you would have read or heard about that. And while we're doing that, we continue to track what happens to COVID-19. We can't just say one wave and it's done. It's going to be with us for a while. Next slide. Next slide. Okay. So just to then start with the triage and testing. You might have seen in the media, and I think as part of the oversight visit, some of you might have gone to some of these places. We are busy, and we have completed Tygerberg, Victoria, Mitchells Plain Hospital, Khayelitsha Hospital, Kraaifontein C8C, Karl Bremer, and Paul. These are temporary rented tents for triage and testing with very good flooring added in. What is under construction is False Bay and Red Cross. And what is in the tender evaluation stage for construction to start next week is Eerste River, Heideveld, Helderberg, and Westvliet. And then Somerset and Grootskep will have a slightly different solution. We will not have tents, but it will be a construction solution that are utilizing existing buildings on those. George and Worcester, Somerset and Grootskep will also have tents, and we're busy with the specifications, but George and Worcester will have a no-tent solution, and it will be implemented in the relevant workshop. Sorry, I got that mixed up. But all of this is expected to be done by the first week in May. Next slide. Then to work with isolation and quarantine, we have to understand that we are working with Public Works, and what they're doing is Public Works needs to understand from us what is the numbers that you require from that forecast model to guide how many quarantine and isolation facilities are needed. They also need to understand how do you do this at the geographic area, and then use a pragmatic guideline to guide what is needed in those places, and then procure a turnkey solution as a first approach to allow time so that we can actually get this going. And based on the numbers, we'll be able to scale up the number of beds required from week to week. And we need to understand what triggers and at what point does quarantine and isolation no longer be effective as a suppression strategy. Because at what point do we say we've now done what we could, and we need to then say quarantine and isolation is no longer effective. Next slide. So currently in the province, we've contracted 929 beds are available. How many are available to be used? Out of the contracted 791, but there are also 842 beds that are potentially there, but it's not been contracted yet. So these are all private hospitals, and we need to go look at them to see, do we want to contract some of them? How many beds are we still looking to activate in provincial facilities? There's 1,145. And the ones we currently use is 546. That's inclusive of placing people in those. Next slide. Then, just to say that I've spoken about testing and triage. PHC, which is the next one, is at 146 facilities. We will be specifically offering testing of primary care facilities. That is 40 in the metro and 106 in the rural. And those places we will capacitate to be able to stream people in such a way that you will still have COVID and non-COVID activities. And the primary care facilities, they need to be strengthened to be able to do that. And remember, a very important part of that is that system is still linked to the community health workers. And those are the teams that's currently going out and doing community screening and testing. Acute hospitalizations, that intermediate care beds for mild cases, that's the field hospitals we're talking about. We have at least 4 places where we are going to commission this 1,300 beds in. It's being planned, and we're at very far advanced stages for being able to prepare and make sure that those beds are ready. Then for moderate cases, we have gone into our own public sector hospitals. This is existing hospitals. And we have reorganized what we do there to create 1,697 beds in our own capacity to be able to make space for COVID. And then the last one, within our own capacity, we've gone into ICU and looked at ICU, and we're adding 150 additional ICU capacity. I just want to make the point, when we make this 150, this is with the 150 in, that we still have the 750 shortfall. The palliative care that we're working on, the team is starting today, is to look at inpatient palliative care, that is dignified dying and support, and then also palliative care in a community-based setting. And the team is working on a model for that. Next slide. So just on supplies and equipment, N95 respirators, there's 70,000 on hand at the moment. We have 2.9 million on order. The Premier did ask us today, and we got a input from the national, from the fund, sorry, the fund that's been set up. And we are also working with our national colleagues that a lot of what we have on order, we will try and get whatever we can, but we will also be a recipient of the national procured stock. And as a province, we will get our fair share out of the nationally procured stocks, working with our central procurement team at national. Similar surgical masks, we actually have 2 million surgical masks on hand, a little bit better than most provinces probably at this point in time. And we have 7 million on order, but we will obviously, if there's national surgical masks coming in, it will preferentially first go to other provinces that has less masks than us, so that at the point where we all have more or less equitable access, we will start accessing surgical masks. For PPE kits, we have 4,000 on hand, and we have 50,000 on order. For ventilators, we have 432 ventilators in the public sector. There are still additional ventilators in the private sector that's not counted there. And we have 100 ventilators on order that, again, with our national colleagues, we will see what comes, but 100 should be coming to us. And then innovations, there's been a range of local production capacity for masks, visors, disinfection booths, goggles, etc. We are flooded by people with good ideas and local innovation, and we're busy going systematically through all of them. Just to translate that into money, stock on hand for PPE is 45 million. Stock ordered is another 185 million. Next slide. So just from recovery and vigilance, just to make the point, most people will recover. As of the 20th, we had 222 people have recovered. And as we go further and further and get more and more cases, more people will recover. Because as you would imagine, 80% of people don't even have to be in hospital. Or most of the people that go to hospital also go home and recover. And a much smaller proportion die. But it's the volume that will push the volume of people that will be infected that push the numbers up. Vigilance is this issue that once a month, there's a national program that will be launched to check a sample of healthcare workers, to check what is the level, irrespective of symptom. Surveillance is you take a sample and you check, are people positive? And we do that on a monthly basis. You have a very clear understanding that amongst healthcare workers, on a random sample, once a month, it would be useful to track across the country what it looks like. When that program is implemented, we'll be part of that. Then the monthly surveillance in public transport, schools, prisons, and workplaces is also something that will be done and driven from national, and we participate in. Then the adverse outcomes, we have developed a protocol for death management in hospitals and community settings. You would imagine we have up to the 17 deaths that I already spoke about. And for each of those bodies, we have a way of managing the body that doesn't expose people. And then the capacity to manage burials and cremations are already referred to. That is something that we're working with municipalities to be able to prepare for that. Next slide. Then there's a question, and it's just to indicate to you what our capacity is in terms of our staff. So we have 13,300. So 41% of all our staff in the health department out of the 32,000 is nurses. So 41% is nurses. Then we have medical officers, which is 2,500, that's 2,400. That makes 7.6%. Then we have medical specialists, which is another 728, which is 2.2%. So doctors alone is roughly 10%. So we have 10% of our staff is doctors, 40% of our staff are nurses. Then we have EMS staff, which is 5% of our staff is EMS, and pharmacists is 1.3, 438 pharmacists in this province. We have 11,000 admin staff, so a third of our staff is admin, and the other staff is people working in engineering and all of those. There's another 8.4 staff. So in a sense, 40% of our staff is non-clinical, 60% is clinical, and that's the breakdown of our staff that we have available. Next slide. So with that in mind, I end off with this, is our staff needs to be protected and kept safe at all costs. So adequate supplies of PPE is an essential thing for us to protect our own staff. Our employee wellness is very important for emotional support to staff that's going through an extremely difficult period and for what is still to come. We've also got this database of volunteers and is established, and the call for volunteers has been widely advertised. We have 1,150 received to date. It's a very good, we're very glad that people are coming forward. This is a spread of nurses, doctors, a range of people that's willing to work with us. And we're also working with our national department, where there is going to be international people coming into the system. People will also be coming to the Western Cape as they're going to all the other provinces. Accommodation and transport needs of staffs are being addressed through collaboration with Transport and Public Works. We are foreseeing a time where infections are going to grow, and it might get to a time from other international experience that we have to possibly start organizing accommodation for our own staff closer to where they work, because it's also their own concern for their own safety of their own families that we have to consider. And then just lastly, we've built quite a big relationship with our organized labor, our chamber, and we view them as essential partners and stakeholders walking this path with us. The last slide. Last slide. It's just in summary. Sorry, another slide. Next slide, sorry. Oh, thank you very much. There's a conclusion. Our strategy should be, we need to be agile and we need to rapidly adjust. I think the conditions change so quickly. This presentation covers our considerations at this point in time. There needs to be unity and purpose and strong partnerships. We are working with everybody to work together. It calls for business unusual, a sense of urgency, courageous leadership from everyone. We see this as an opportunity to fast-track health system strengthening towards universal health coverage and a whole-of-society approach. Thank you very much.
Thank you very much, Dr. Kluti, as well as to Minister Mbombo, the DG and the Premier for the presentations that you've made. I'm going to ask that we pause the meeting for 5 minutes for a quick break before we resume with questions. I'll ask that members please stay on the line, do not disconnect from the meeting. We'll simply pause it, and if you could please put your microphones and cameras on mute, and we will then reconvene at 15:31. Thank you very much.
Thank you, Chief Whip.
Thank you, Wasim Ozaira Otafsir, for this. Yes, Wasim, it shows.
Lizette, get off the speaker.
Right, good afternoon, and we're back. Thank you again to the Premier's Department as well as the Health Department for that very informative presentation. I know that members have a number of questions and are looking forward to engaging with you. So thank you very much for making yourselves available this afternoon. So far, I have Honourable Dugmore, Honourable Mackenzie, and Honourable Philander that would like to make some inputs. Shall we start with you, Honourable Dugmore? Please proceed.
I'm just unmuting. Hi there. Hello. I just want to check.
We can hear you loud and clear.
Why,
Proceed.
loud
Okay.
and clear. But
Thank you.
to put a camera, it's still the wrong data.
I mustn't
Honourable
do
Dugmore,
what?
please proceed. If you would be able to just tell us to whom your questions are directed.
Okay. The first question to the Premier, and then one to the MEC and another to the HOD. But I would like to start off, Chair, with just paying tribute to the Health Department. The response that we got has indicated that support was provided to the person in Khayelitsha, and that situation is being handled. I really do appreciate, I'm sure as all of us do, that particular intervention. My first question to the Premier relates to the issue of how we can build the broadest possible participation at all levels and amongst the communities themselves in terms of this pandemic. As far as we see it, we've got the immediate and ongoing challenge of reducing the spread, and we've seen that. There's the issue of poverty and hunger, and then all the economic issues. And our view is that we all respect that there was an election and there's a government in the Western Cape, that when it comes to the various levels of command, the Premier has explained to us about how the cabinet is working, and the HOD of the province also told us about the streams that they've set, the clusters and so on, and then different levels of the job. Now, the Premier would recall that in this process where we've been communicating, we've sent a letter specifically asking that when it comes to the provincial level and then also the local government level, that we were not suggesting that public reps should be part of a JOC, but we were requesting that a councillor who wanted to go to a JOC to give a report or to visit should do that. And I know that there were emails sent to the various municipalities, but the problem that we're having is that in some municipalities, there is this council to make sure that there is engagement. And then at a provincial level, I think, and I'm sure we'll discuss that at the meeting with the Premier and the political parties at 5, but at a provincial level, for instance, on some of the key issues like the question of food security, we believe that a provincial joint command, which would actually assist to bring in at a level, the leadership that is there in the legislature, together with the Premier, so that there can be an inclusive approach where we deal with issues of partisanship, the issue of communication. So I want to ask the Premier, in terms of the provincial, district and local JOCs, what is his view about how public representatives from across the political party divides can be part of the processes that are being driven by government at these particular levels? My question to the HOD for health is mention, and the MEC, there's mention of a lot of construction that needs to happen to set up the various facilities and so on. And there's, for instance, there's been a particular offer which I know has been communicated around assisting with the construction
of beds and particular units from the Baxter Theatre. We have got expert artisans who build sets. So how do we actually look at the issue of involving people in actually helping with the construction that needs to happen? I think the last issue to both the MEC for Health and the Premier, we are fully aware that municipalities have a responsibility to provide for the homeless. But we are very concerned that our provincial government has not in any way raised their voice around what is going on in the Strandfontein camp. Now, we know that on Friday we're going to have a specific engagement on social development, but from a health perspective, and there were some reports about testing that has been done, but anyone who has gone there can see the huge risks given the movement of people in and out and the way that that facility is being managed through with different NGOs. Does the Premier and the MEC believe that the health situation and the compliance with the regulations is actually being followed at the Strandfontein camp in particular? And are they happy that in regard to the health issues, that at all the homeless facilities, and we've heard that some municipalities have not set up any facilities yet, that the health issues are being managed correctly?
Honourable Dugmore, do we still have you? Have you concluded?
Yes.
Thank you, Peter Marie.
Thank you. Please use the chat bar if you'd like to pose a question. All right, I think that's quite a fair number of questions, so I'll hand over to the departments to respond before we take the next members' questions. I don't know. Minister, would you like to start?
Yes.
Thank you. Please proceed.
Okay. Okay. Starting with in terms of the last question. Thank you, Honourable Dugmore. The last question. Personally, I'm not satisfied with any of the issues related to social distancing, to all other 5 golden rules to prevent COVID in any other space, not only in the 3 camps, not only in the Strandfontein, but even to the people who come visiting health facilities. I mean, for people who are coming for their own illnesses in any of our facilities, where you can see people are queuing outside, and some they don't even maintain the social distancing. I'm not even satisfied with what is happening in our shops, supermarkets, where they are so full, there's no social distancing anyway. I'm not even satisfied in the context of where people will be, whether it's a land invasion or occupation and so forth, when we have got a large number of the gatherings. I'm not satisfied. So what is happening there, what he has mentioned, is a manifestation of what is happening in any other spaces, of which is most of those spaces are beyond health. It needs the whole of society in order to be able to tackle the issue of the social distancing, of the hygiene, including surface hygiene, and then the issue of the social determinants of health. That includes the issue of the food security, the issue of the safety, and all of those. Now, specifically on what is indicated, fortunately, the Metro Health, unlike other 5 districts outside where they've been provincialized, it's not provincialized. The City Health has got their own facilities. They do have their own staff and everything. In the Mitchells Plain specifically, they have, I think, 5 or so clinics. The nearest clinic that is there is Strandfontein Clinic. In some parts in the metro, they have fully fledged comprehensive package, full-time doctors, just making an example, in the Bella, the new one in the Bella, and all of those. So the point is about that. For any shortages or challenges that are related to the health, the city can be able to manage. Currently, I'm aware that they are rendering the services until 4 o'clock, which is not unusual per se, because in most of even our facilities, they end at 4, and then you have to have a facility within less than 5 kilometer radius for the referral. For example, in the Mitchells Plain, we do have Mitchells Plain Community Health Center 24 hours. We have got the Mitchells Plain District Hospital 24 hours. We have got the Lentegrier Rehab 24 hours. We have the Lentegrier Mental Health 24 hours. So it means that for any of the other smaller clinics, inclusive of the health services that are rendered at the camp, it doesn't stop for any person who's being seen in there, because there's a tent, they have medical facilities, they can be referred to. And also, luckily, the city is the one who has been providing what we call these drug matrix, which I've seen in the Delft, in the Khayelitsha, and all of those. So they are capable to provide any services in regard to, I'm talking about when there are issues of the drug addiction withdrawals. So a city on its own, as we know, that it does provide the packages. Our responsibility, which now they've also raised it with me, it's about the issue of the EMS in terms of the delays, which is, I think we have sorted that. And again, it's a work in progress, in need of when there's an emergency in terms of taking the person from the Strandfontein to whether to the nearest 24-hour CHC. So we are fine with that. And I'm aware that in the others, like in the Belleville, where already we've been in that space in regard to some of the COVID cases that we identify, and already they've been they are in our isolation areas. So yes, indeed, Honourable, that in terms of the regulation, in terms of compliance, they do comply because the city is a service provider for the health. And then the second question about the construction. The HOD did mention in terms of the INQ sites, and plus also the triage and testing sites, and also some of the field hospitals in planning, which is one of those. I think he did mention is a city ICC. So where we are, in terms of where we are, I think he did mention in terms of the potential, I think 700 beds, which if you look in terms of what the city ICC could provide, in terms of the modeling, we are still fine unless things change. Of course, we are not closing in terms of that if there are any other opportunities around that, but take into consideration that in terms of the lockdown, there are also other sectors where we find that we have to tread carefully in terms of opening up for the space where it might not create social distancing, or there might be impinging on other regulations in terms of the movement. I'm not sure whether Dr. Klute, if you want to add anything before we give it to the .P.
I would just like to add, if any member has any information about anybody that can produce or help or assist, I would encourage them to email me, because we have a system of looking at all offers of donation, all offers of wanting to add skills. And we have like the volunteer base. We look at all options. We contact everybody. And so if there is people that can contribute their skills in terms of bed making, in terms of this, in terms of that, please forward the details to me. We will follow up with everyone. Thank you.
Thank you very much. .P.
I'll come in. Okay, Chair, I'll come in on that. Thank you very much, and thank you very much to the Honourable Member for the questions. I'll go first, which is around the Joint Operations Command. And of course, we have to, we're all in this together. If we don't all stand in this together, we are not going to get through it. I think what Health put on the table yesterday around our modelling, and what Prof. Karim puts on the table around our modelling, shows that when we get to, in our province now, the 80,000 infections in 1 week, we are going to be under severe strain in every single one of these work streams. And it is about preparing for that now. And of course, we all have to stand in this together. So I agree. And obviously, we need to be able to do that in a way where we can continue with an oversight. We can continue with our existing jobs. Because obviously the regulatory environment is quite clear. I mean, we've agreed that our Joint Operations Commands, that and you have sent a list through, Honourable Dugmore, to say which people are relevant to oversight. You will also know that in the regulations it's quite clear as to who should be in those jocks. And in actual fact, very few politicians should be in the jocks in any space from a governing point of view, let alone from an oversight point of view, because we want to make sure that it is run properly. The jocks then report back to the executives, and that's why those regional jocks, they have a system where they report back to their regional executives, and of course we also then bring them into our provincial executive now, as the DG said. So we have them coming into our three times a week cabinets. Those mayors and municipal managers from those regions link into the oversight, but of course the jocks themselves, they all link to themselves. And maybe I can also just add one other thing around the jocks, that we raised a concern because the jocks themselves were having too many meetings with people in the room versus people coming in online. And I know this is the first Parliament online, and we were just commenting earlier that we also remember our first cabinet online and the first, second, third cabinets online. And sure, we had some issues about getting our documents up and people dropping off. But I mean, now it's running smoothly. We have huge numbers of people coming in on our weekly, or our 3 days a week cabinet. 20, 30 people coming in at a time, and sometimes into the PCC, we're getting close to 60 people going into a PCC at a national level, all through teams. And it starts off a little bit difficult, but now it seems to be running well. And if there are areas that are blocking people, then please just let me know. We'll raise it through Minister Bradell and get that dealt with. That is part of the process. And any other suggestion, let's have a look at how we can build this, bearing in mind our core responsibilities. But of course, we've all got to get through this together. The second point around, I'll get to the homeless and the shelters, the last point, but the point around construction, and I think Dr. Kluti answered it, but perhaps also just to bear in mind that from a supply chain point, they're building lists, so people have come forward. I know that just on face masks alone, at the last report, we had more than 140 different local suppliers who've registered their ability to make masks. These are CMTs, people, the small little operations right up to big operations. And really, we're pushing quite hard. There's also been a plethora of people from international markets trying to sell product to us. But I think the work that's being done at the moment between the Department of Health and Economic Development, trying to support local, is really great to see. So that, as we're spending money, let's not spend money on imported products, especially when locals can compete from a price point of view. And that's from anything into the supply line. And then the last point on shelters. And I agree with what Minister Mbombo said. Of course, we are concerned with all of these reports. Remember, we have an oversight in the province. We don't have that much direct involvement other than social development and health in the 34 shelters that we have in the Western Cape. Looking at South Africa, there are 166 in our country with 14,309 people in those shelters. In the Western Cape, 34. There's also 34 in Gauteng. Gauteng has 3,000 people in their shelters. We have 6,681 in our shelters. The three biggest shelters being Strandfontein, Wingfield, and Paint City. And each of them have various issues. I've noted the Médecins Sans Frontières report of last week. It also gets reported by the city at our joint meeting and comes through into reports to me as well, because I'm keeping an eye on it, looking at the numbers of people and what some of the issues are. And I must say, it seems to be slowly but surely getting better. The one problem, I think, at Paint City is now we actually had an extra 125 people come into Paint City. We've still got some issues there around, we need some more taps and some more mobile toilets, some lids on the bins, and extra soap and sanitizer. If we look at Strandfontein, some of those issues. Yesterday, I was in contact with the Human Rights Commission on some of the issues there. I'm glad to see that that number has dropped quite substantially. We're now down to 1,072 people at Strandfontein, spacing getting much better. And, these are difficult issues. They're not, they're across our country, and we really are trying to fix them across the country, and obviously trying to fix them right here where we have that oversight. I had a discussion this morning with social development, specifically around some of the issues raised. At least Strandfontein has quite a high volume of medical professionals now that are there every day, unlike some of the other sites which don't have that facility. And right down to this morning, the discussion was how can we very quickly see if we can get sanitary pads delivered, and Minister Fernandes has looked at that. Then, there are some other issues, and I can go into further detail if you want. But also bearing in mind that this is one stream, and we could put 24 hours worth of healthcare, but our healthcare focus is actually on the next level. And the next level is the quarantine sites, the 8,042 quarantine sites and another 1,145 that we're adding to it. At the moment, secured 1,582 beds. I see we've gone up as of today to 101 people now in isolation. These are people who are actually in isolation because they're positive. They're being removed, just as the call that the Honourable Member made earlier on in this program, that someone has been identified. We need to make sure that we're getting them into spaces, they're getting the care that they need, they are isolated, and their family members or the contacts. I think 546 as of today in some of those facilities. And then, of course, there's the next stage again, which is where the big money is being spent, and that is getting ready for the onslaught that's coming at us. That peak of 80,000 infections, and of course, that's what I think mainly the focus of Dr. Kuti's presentation on how much have we got in stock, and have we got enough supply coming. And our experience so far, we've had stuff on the way here, and it gets diverted at the last minute. So it's really monitoring and managing for the actual infection and an actual COVID. And of course, that's where the main focus is. And then, of course, we'll move on to food, which I'm sure will be a couple of questions too. And then, of course, on the food thing, perhaps to say that the big focus of our government will be on Friday, where we've asked to see how much of food we can map. Because it is actually all over the place. There's so many providers, and that presentation is coming on Friday, where we're trying to pull all of that together so that that we can kind of get an idea of where the gaps are in the system.
Thank you, Mr. Premier. DG, would you like to make any additional inputs?
No, Chair, I'm okay.
Okay, thank you. All right, we have a rather lengthy speakers list as follows. Honourables Mackenzie, Philander, Heron, Nkondlo, Syed, Wenger, Winvogel, Christians, Trejo, Murray, Mitchell, and Lecker. So I will then now recognise Honourable Mackenzie.
Thank you, Chairperson. Can you hear me?
Yes, we can hear you. Please proceed.
Thank you, and thank you for the presentation from the Premier and the two DGs and the Minister of Health. And I just want to say thank you to all our frontline officials, law enforcement officers, police, everyone out on the street who's doing amazing jobs for the last few weeks. It's all new to us, and there's not going to be any perfect plan. I just want to check with the Premier, given last night's announcement by the President and going forward over the next weeks, and the province's strategy as presented by the DG, and we know any strategy is changing. Like I said, this is changing environment on a daily basis. What is the province's, or are they going to make any changes to their strategy going forward over the next 2-3 weeks, including if the lockdown is going to be a smart lockdown or a phased lockdown from the 1st of April? And then second question to the Premier, given there's been various reports around looting of the stores, we saw trucks being hijacked, around legitimate issues such as food parcel as raised by other members, I'm particularly concerned about the criminal element in this. In one practical example, a truck of alcohol was stolen and looted and was found empty in Mitchell's Plain. Now we know those were not individuals looking for food parcels. We saw last week in Elsie's River, individuals looted local top spa, etc. So those were not the individuals looking for food parcel. Clearly, individuals intended to loot and to cause mayhem. Has there been any interaction between the Premier and our crime intelligence community or state security about the criminal elements of this, not the people who are genuinely need food parcel and are currently helpless, but has there been any interaction about the, which I believe the vast majority of individuals stoning trucks like we saw on the R300? It wasn't our grannies or people in wheelchairs needing food. It was individuals that seemingly just want to cause mayhem. And so I just want to find out, has the Premier been in discussion with our state security and our intelligence agencies around this? And has there been discussion with the Prof joins about ramping out security presence in our communities? Again, there are genuine concerns, but there are individuals who loot, then run into streets where Mrs. Kumalo and Auntie Bida stays, who is sitting on a porch bothering nobody, and they can potentially become harmed. So has there been discussions around that in the Prof joints? And given the current state of our economy, and last night we heard about the 500 billion rand, and it seems that it hasn't been this. And this morning I was a conference call with the Financial and Fiscal Commission, with Treasury, and they still seem to need to have meetings. And yes, Thursday's announcement by the President is going to make, but there are immediate needs. Have they been in discussion with you, allocated more funding towards how some of these things can be implemented? And should the lockdown be lifted on the 30th of April, and we all know there's no magic button that can be pressed, has there been only consideration from the Provincial Cabinet or discussions around what industries can potentially resume after the 1st of May? And then some questions for the Director General. The Western Cape governments employ tens of thousands of employees. And a lot of these employees, except your health sector, a lot of these employees work in your call center or in supply chain management, guys who's currently dealing with transport and public work, etc. He talked about the 11,000 administrative workers working in the Department of Health. Has there been any discussions? And I know that earlier on, you talked about communication strategy, and how do you communicate with the Western Cape government employees not in health and education that are currently going to work every day, and what risk mitigation sections that, or plans have you got in place for those tens of thousands of employees, supply chain management, staff, etc., who needs masks or needs hand sanitizers? Is there a plan in place to sanitize some of your government buildings in the Western Cape, for example? If people do go back to work from the 1st of May, we all are cognizant that some of these buildings and the health experts can talk to that. Some of these might have some sort of possibility of some virus. Are you going to clean their desks, their computers? From a government perspective and from the tens of thousands of employees that serve our community, the Cape Access Centers, people are going to want to type up their CVs after the 1st of May. So people are going to use those centers to access government services. So is there a plan, and what is the plan to ensure that our employees, when people go in and out of these e-centers, don't become spreaders of the virus? And then the questions to some questions for Minister Mbombo. In terms of testing, and we've seen globally around testing. And last week I was very privileged. I went around to the community in Mitchell's Plain, Heinz Park. We did loud hailing as public reps to get people to come to Heinz Park and Lentegeur and come and do community screening so that we can, with you and your technical experts there, can see where these fires. So what is the plan to ramp up the testing? And do we have enough testing kits available, whether you get it from the national government or for the province on its own? Is that something that we've got in place going forward, given that the potential risk? And then, you know, that there's been a lot of talk about antibody test kits. We've seen people that have been tested positive and can be in the negative, and I saw a very interesting article the other day that a small percentage, although 3%, has tested positive again. So has there been talks or thinking in the Department of Health going forward about antibody testing? So individuals that we can say, hey, Ricardo, you've had it, you're now clear, you can go back to work. And then given the state of our healthcare workers, and thank you for the presentation earlier on, are we doing enough to ensure our healthcare workers are protected and also receiving the necessary support? And here I'm not only talking about PPE, I want to talk about the mental health support, because going out, and I as a public rep, you know, when you do door to door, street to street, when I come back, I took off my shoes at my gate and I rushed straight to the back into a shower. So it becomes personal, and those individuals dealing with patients in high care or ICU, I can imagine when they get home in the evening how they feel. So what is the plan in place? And perhaps the Director General can also speak to that, from dealing with the mental care, the mental health of these tens of thousands of our great public servants that go home to their families, the nurses, the doctors, etc. And then final point is, when it comes to the ventilators, and earlier on one stat was made, I just want to get clarity. When we talk about those people in ICU, does it mean they all are on ventilators or not? Or are they just in ICU as we know it? And then the last point, earlier on I think slide number 16, there were talks around the screening that was done. I just want to go to my numbers quickly. On slide number 16, we talked, I think slide number 17, the number of people that were screened in the metro was 48,000. The number of people in the rural was 32,000. Now, given the amount of people we have in the metro versus the number of people in the rural areas, those numbers are quite close. If you look, even if those tested positive in the metro was 3,000, those who tested in the metro was 3,678, rural 140, and the percentage of the metro tested positive was 7.5%, sorry, tested 7.5%, and the metro 0, and the rural 0.4. I'm just trying to understand, are we going to ramp up more screenings in the metro? Understand that we're chasing the bushfires, but just seem to be too close numbers given the discrepancy in population in the metro versus our provinces. And also final point, what is the international best standard? Yeah, what is the international best standard when it comes to the percentage population tested versus percentage screened? Thank you. I'll wrap up there.
Thank you very much, Honourable Mackenzie. Premier, if you'd like to respond to the first cohort of questions raised by Honourable Mackenzie, please.
Chair, I'm happy to do this, but then I was wondering whether we should actually start to cluster maybe 3 questions at a time. But I'm happy to deal with this to start with. I think the first one.
If you are happy to take a number of questions, because we do have a rather long list of members who would like to pose questions, I can take a few at a time. Should I proceed, Leslie? Okay. Honourable Philander, you are next.
Thank you very much, Chair. I echo the sentiment of the previous speaker, saying thank you to all our frontline workers and everyone that's working extremely hard. Chairperson, I would just like to know the volunteer workers. I think Dr. Klute mentioned 1,100 plus. It's really heartwarming to hear that. How does those workers get incorporated into the system ultimately? And then, Chairperson, my next question is to the DG, the health budget as it is. And the Minister mentioned that we must not lose sight of the fact that at the health facilities, it is business as usual. So how does the current affairs affect the current health budget of this year? What are the effects thereof and the implications? And then, Chairperson, my other question, something that we don't speak easily to, that is in terms of municipalities. How ready are they in terms of grave sites, arrangements for burials and cremation, and also very important, our mortuaries. Will we be able to deal with the volume should we get to that point? Chairperson, you want me to ask all the questions now?
If you do you have a lot of questions left? Or if you've got just a few, then please proceed.
Okay, thank you very much, Chair. And I think we've also now learned about the rural cases. In the case of Witzenberg, the local infections and Breede Valley, which in a small space of time has quite spiked. What is done in those, what government efforts are those to contain those spread and of course in those rural areas, as mentioned, Witzenberg and Breede Valley. And I think it was mentioned about the ventilators, the capacity, the bed capacity, Dr. Klute did touch on. The PPE availability was touched on. And I think just coming into the PPE, the selling of N95 masks, or is that matter dealt with by trade and industry on a national level? Or is it the department? And I'm sure the answer will speak to, as it was mentioned previously, to the global shortages of production. And just to add on, I think the DG did touch on it, has local businesses been asked to assist in production thereof? And if so, how far are we in the process? And then, Chairperson, also over the past few weeks, what has the impact of COVID-19 been on EMS services in general in the province? Yes, I think I will stop with that now. Thank you, Chairperson.
Thank you, Honourable Philander. And then the final member for this round is Honourable Heron. Over to you.
Chairperson. I have a lot of questions, but we're running out of time, so I'll just ask the Premier one and the MEC for Health one. My question to the Premier, on Friday we will deal with food security in more detail, but I do want to raise an issue with the Premier, and that is around the politicization of access to food relief. And I think it's quite urgent that it's addressed in this province and I don't think it can wait till Friday. The Gauteng Premier has announced that councillors cannot be or should not be involved in the distribution of food parcels, which I think is correct. But he is allowing councillors to identify beneficiaries, which I think is incorrect. Now, I've received over the last few days a number of complaints around the politicization of access to food parcels. And when I've questioned some of those allegations, I found that it relates to the Department of Social Development's food relief scheme. And I would like the Premier just to listen to this, because I think it's quite important that you understand what I'm talking about, because this is one example of many that I've had since Friday last week.
Afternoon, Rick. Hi, this is Ms. Jacobs here. I wish you are well, but I was just a bit perturbed this morning.
What's happening now?
Nazanin was taking names here. My neighbor told me this morning for food parcels. I can't talk long because of my eating. For food parcels, and when the
Honourable Heron, we seem to have lost you.
I'm back.
Good.
Oh, sorry.
Could you perhaps just summarise the voice note for us?
Just a bit. Because Nazanin was taking names here. My neighbor told me this morning for food parcels. I can't talk long because of my eating. For food parcels, and when the neighbor said, what about Mrs. Jacobs up here and her husband? So she, Nazanin carried. So she said, no, they can't get, they're not DA, they belong to good. Even the two neighbors downstairs also. So I just need your guidance here now, because is it a corporate thing or is it a political part?
So I think this is an example from District 6 that I received this WhatsApp message. This morning I was in Mitchell's Plain delivering some food to a food scheme, And a woman approached me. She has an 85-year-old mother, and her mother was told she can't get a food parcel because she doesn't support the DA. I was in Khayelitsha on Saturday also delivering food, and I was approached by Khayelitsha Development Forum leadership, and they told me the same thing is happening in Khayelitsha. So, Premier, I'm really urging you to intervene and to pull councillors out of the distribution and the identification of food, because it's been politicised. We have an ugly history of it in South Africa. We've heard the president express disgust at ANC councillors who've done this, and we cannot have this happening in this province where people are getting access to food based on who they support as a political party. If I can quickly just ask the MEC for Health and or maybe Dr. Kluti. I really am struggling to understand the demand for beds versus the supply. There were a lot of numbers thrown out. There's the acute, the ICU. You talked about hotels. The slide said hotels, but you said hospitals. There's 8,042 beds, but I think the slide said hotels, although you said hospitals. So what are we doing? Are we going to be procuring hospital beds for quarantine? And that there are tents being set up at existing hospital facilities for testing and screening. And then there's another 100-odd sites that you're adding for, they're called PHC sites, Provincial Health Clinics, I assume, for screening, testing and triage. So what is the deficit in terms of beds in total? And what are municipalities and providing in terms of facilities to support the need for beds? I mean, in the city of Cape Town, are we using the convention centre, which is partly owned by the province and the city? Thank you.
Thank you, Honourable Heron. I'll then hand over to the departments to respond to those three members' questions. Premier, I don't know if you'd like to start, please.
Okay, sure, no problem. I'll go first. And I suppose the DG can top up here from our side, which won't be the health answers. But the first, Honourable Mackenzie spoke about the President's announcement. And I think right in the beginning, obviously some of the work that happens we're fully aware of because we are involved in some of those work streams. But we didn't have all of the detail, and that's why you would have seen today, I think the 3 min-max happened today. The finance department, the finance budget council only gets together tomorrow. The DG's got FOSAD tonight. And of course, what happens is it does create a bit of pressure on the system. I know that social development and the call centre has been inundated with people to say, can I get my 350 Rand? And of course, we don't even know how that's going to go down. But what happens now in the next few days will be all of those meetings that are taking place as to exactly how it's going to affect us, our 5-year plan, our budget. We know all of those things are going to change drastically. Even much of this funding, 130 million is going to have to be sourced. 130 billion of the announcement last night is actually sourced from existing budget. So there's going to be massive budget changes happening because, of course, we're not going to have the income from a tax point of view, and also we're going to have to redirect much of that money. And so many of those, I can't give you answers yet because all of those meetings are still happening as we're going. I am very concerned about the looting. Your question was, how do we engage with it? Every single cabinet meeting has a report back from Brigadier Zandberg from SAPS, as well as City Law Enforcement, Director Roberts in the same room reporting back every single morning. It's at Prof. Joints and at the JOC. And this is where both the State Security Agency, SAPS, you'll see extra deployment of military. We don't know yet. We were asking the questions this morning, how many extra military are we going to get? Because obviously these hotspots are exploding all over the country, but here we definitely see it exploding into that looting space. And as you say, the problem is that these criminal elements are then jumping in, and then what happens is the poorest of the poor are not getting what they need in that delivery process. But what you're seeing is not the full impact. This morning alone, we heard of interventions that happened because intelligence was picking up what was happening on the ground, where people were motivating people to come out and loot, and the information was coming out. And when they got there, the law enforcement and SAPs were on site, to actually stop that specific looting happening. But it is very concerning, and it is very much part of us building up over the next few weeks, because it's the unrest, it's the looting that is actually the next biggest risk coming at us post the nutritional food security risk. The economy, this Saturday's PCC with all premiers had a big focus on health, but it also had a big focus on the economy, and obviously on the economy leading up to the announcements that are going to be made on Thursday by the President. That meeting was a 4.5-hour meeting. And of course, we're in there, as well as our departments, putting forward not only what that new lockdown or new normal is going to look like, and our suggestions around our sectors. You will also notice that it looks as though when relaxation comes in provinces between the health department and myself, we can also, where perhaps a relaxation comes in, we can also then push it back up to full lockdown if we feel that it's going to create too much of a problem or too much of a risk for us in a management process. Obviously, we can't do the opposite. We can't open it up, but we could tighten it up. I'll leave the employees for the DG. The new normal protocols I have spoken about a little bit, but every sector has to come up with new protocols, just as we have to in government. And the DG can speak about our ones, but every single sector needs to say, what are they going to do to make sure they're not spreading the virus? You heard from Minister Mbombo now. Any frontline space right now, whether it's healthcare, whether it's retail, those are the front lines, and our factories, those are the front lines where the virus is spreading. As soon as we relax anything, then new front lines are going to actually develop, and that's why we need to have protocols as quickly as possible. Then the Honourable Philander, the volunteers, the health department can talk about how they're going to be used. The municipalities, that's also part of what the JOC and local government are dealing with. They're looking at capabilities, they're looking at extra or shortening processes so that they can find extra space for graveyards. It is part of that model that we released yesterday, which says this is what we're predicting. Then what does that mean for every single department? So if we're going to have 80,000 infections in that week, what does that mean in how many people are going to die, and then how many, whereabouts, and how much space we have in our mortuaries, and then processes to, whatever religious or whatever burial process has to take place after that. And so we're busy on it at the moment, looking at the gaps and how we fix those gaps. And then the last one that I'll answer is the one by the Honourable Heron. Absolutely 100% agree. A real big problem is when politics comes in, specifically around distribution of food. And I agree with the Premier in Gauteng. I agree with the Premier. Last week, the political party that I belong to actually sent out a letter to all political formations to say that this is not to be done at all. And I can tell you that from our own provincial cabinet decisions, when we involved in any distribution of funding for any food, we actually put riders in there that no political process or no political handout can be involved. And we need to make that very, very clear that that is one way that we're going to end up with disaster. It was part of the presentation this morning. The Cabinet had a presentation from the Solidarity Fund, because they are also obviously involved, but that goes to the other question around that the Honourable Dugmore asked, is around the coordination that he wants to talk about later. You've got all of these role players, of which most of them are non-governmental, and you need to try and make sure that we get the politics out of it and that we actually get the food delivered to those that need it, without being looted on the way or getting double dipping to other people who actually don't need it. DG?
Chair, I'm going to respond to the issues that were raised by both Member Mackenzie as well as Member Philander.
Thank you.
Let
Please
me
proceed.
start. Excuse me, Chair. Can I
I
proceed?
said thank you. Please proceed.
Okay. Okay, so I'm going to respond on the issues around our employees, and I mean, I need to state it right up front that, I mean, the health and safety of our employees comes first. So what we're doing from an institutional perspective, we monitor the amount of people that's currently infected, from a staff complement perspective, both in the health and outside of the health space, and we strictly follow the health protocols that's been put in place in relation to our staff members, whether they've actually been put into isolation or even those that have come into contact with people that's been positive, and we're following the guidelines that's been set aside to deal with quarantine particularly. So what we do institutionally, I mean, departments, so we've put a process in place for departments to report where particularly staff members, got into contact with people, that is COVID positive. I mean, we recently had examples, particularly within the traffic department space. And what we've now also discussed as a provincial top management is to consider to potentially explore the use of private sector providers, so that particularly where our frontline staff get into contact or may perceive to have contracted the virus, to actually go for the respective test, like in the case of some of the traffic officers. And we also believe that we do not necessarily want to overburden, the current public sector health provision space. So in that regard, I mean, the PTM is still taking that under advisement. I also need to state that in respect of considering staff returning to work potentially, in May, as a PTM, we've also agreed to actually develop particular protocols, and some of those protocols include making sure that when staff return, that we've got the appropriate PPE available. So what we're actually considering now is particularly when staff members become ill during the workday, that they go home immediately. We will continue to uphold the protocols around social distancing within the work environment. Obviously, the practices of good hygiene, the issue around distancing as much as possible, as I've indicated, maintaining clean surfaces, wearing masks or other personal protective equipment, when particularly for those staff that actually deals with the frontline public staff. So the plan is actually to put a protocol together which will serve at PTM, but we've already started to engage with the Transport and Public Works Department to at least make sure that the current surfaces are at least cleaned up, and then making sure also that we've got the required PPE available for our staff. So it is about sanitizing, it's about making sure that the work environment is clean, and then obviously to give the staff the necessary assurance that we actually care for them whilst we actually remain within the particular health protocols that's actually been set out by the Department of Health. Then in relation to deal with the psychological impact, I mean, we've already had that discussion as a provincial top management, and I've asked my team within the Department of the Premier actually to consult with our employee health and wellness providers, Metropolitan, to actually put a process in place where staff can actually access those services in addition to the ordinary services that they actually are providing. So I'm just awaiting a report from my staff, but that is effectively what we're actually putting in place, because we understand that it's important that if our staff is well, then they can actually deal with the public out there in terms of assisting them within the broader environment. So in closing, Chair, I mean, as I've indicated, the safety of our staff comes first, and with us obviously providing the services to the public out there, we need to make sure that our staff feel protected, that they are protected, and that we do what we need to do from a employer perspective to make sure that the necessary issues are in place, where staff actually feel that they're actually valued and that they are protected in the space. Thanks.
Thank
Chair?
you, Mr. Malina. Yes?
Chair, can I just respond to the question of Member Philander? And I'm sure the HOD of Health will also talk about it. Within the Cabinet PTM space, obviously finances is a stream, and Cabinet has already agreed to certain measures to deal with expenditure of an extraordinary nature, in particular expenditure from an unforeseen and unavoidable nature. So the Department of Health reports into that stream. I am aware of some initiatives afoot up north in relation to dealing with some of the emergency stuff. But at the moment, departments have been requested as far as possible to try and reprioritize current budgets to deal with the outbreak of COVID. And I mean, that arrangement is also in place for the Department of Health. Obviously, understanding that the implications of what they need to deal with is actually massive, and it's actually out of the ordinary. It's not normal, and therefore Cabinet has agreed to actually put the necessary measures in place to deal with expenditures that is actually falls outside of the initial budget provisions that were put in place in the beginning of this year. Thanks.
Thank you very much. Department of Health.
Thank you, Chief Whip. Can you hear me?
We can hear you, yes.
Oh,
yes.
Okay. Then the HOD can add. Some of these responses, I'll just lump them all together. Member Mackenzie, I must just say that health sector or health systems, they are having a privilege that at least for them, they can use evidence because you are the data collectors and then interpret and analyze and then they make projections. So generally, not only the Western Cape, I'm talking at the national level in terms of the response to the COVID. Hence, for us, we already make some of the input towards for the national command to make some of the decisions in terms of what follows after the 30th of April. Just to make an example, because we're talking about the post-lockdown, just making an example. Already, we know that the people who get affected most, whether death or even in terms of the being critically ill, it's mostly the older persons. It's mostly those who have the existing comorbidities, who have got more than one conditions like cardiovascular and so forth. Therefore, because we know that also during the winter, we find that these are the most people actually who even get affected, inclusive, of course, others who might have other compromised immunity conditions. They are also even affected generally with a range of common cold. Therefore, my point is, when you plan for post-COVID, therefore, you have to look in terms of how do you protect those kind of the population in order for them, even if there is because remember, it's up to the president, the national command, whether to lift or to phase and whatever. It's just making an example that, therefore, it makes it us to be able, in our own space as health, already to plan on post-lockdown or in terms of the phasing out of the lockdown or the restrictions. So we do have something in place specifically for us, health, and also we do advise as part of the provincial command in terms of how they're supposed to work in this space. Testing kits, as you are aware that currently we're still using the molecular diagnostic lab testing, which is the swabs, whether through the mouth or through the nose, and then they need a lab, and the testing is done by the medical person. Of course, the issue about capacity and also at what extent that we can go further than that or to build more capacity. Currently, because we haven't built enough antibodies in order to do other tests, whether the serology, which is taking the blood, so those ones are furthest. But to to beef up the testing beyond the molecular testing at the national level, already there's a talk about the point of care, which is a rapid testing kit, where they use the gene expert machines that become mobile. They can be placed everywhere instead of only waiting for all those, to the national lab for the others. But remember, the virus, not only still new, but it impacts differently per each population. Country-wise and within a country, how it will impact Western Cape will be differently when it impacts, for example, the Eastern Cape or other. Within the Western Cape, how will it impact the metro? It will be different from how it's going to impact, let's say, the Weskus. Same applies within the metro, how it will impact the Southern District will be completely different how it will impact the Eastern District. So that's why you'll find that, as I think the HOD did indicate that, whilst we use the existing data from the other countries, but it becomes quite difficult actually to copy and paste and transplant them as it is. Okay, I did mention, because you're asking our issue about the ventilators and ICU and all of those. I did mention that, remember, there's 80% of the population that still have to be managed outside the institutions. So they won't be hospitalized, but these are the ones who will have a sore throat this day, and then maybe they go to the hospital. At what extent that we are ready for those, because they might not need for admission, as I indicated, or acute. But how do we ensure that you relieve them from that sore throat, or you give them the oxygen if they have got difficulty in breathing? So I don't want us to focus too much on the how many number of ventilators, the ICU. The ICU that was mentioned is about being prepared in case where you find that there are many of those. I think the HOD did mention that even currently, without a COVID, the issue of the ICU bed in the public space, which is, I know that in the private space, they've got so many of those, is still a challenge. But you mustn't lose a focus that we need to strengthen even at the primary care level. Auntie Sarah, when is COVID positive and then presents with a difficulty in breathing, that person may be hypoxic, meaning that there's no oxygen coming in. So without even going to the ICU first, it must be that when she goes to retreat, for example, at what extent that she'll be assisted without waiting in the queue or in the same queue with the others, plus also that to get immediately the oxygen, if there's a drug that is required to do that. Hence, it answers some of the questions that member Heron also asked about. What are all of these? Hence, we have got these triage and testing sites. In some, the 17 that we have planned, others already there, where we find that it's like a marquee kind of temporarily, where people, instead of going to the same emergency, but at least they could be diverted and go to those kind of the tents, triage and testing sites, where they immediately will be triaged that I do have a respiratory problems. Yes, go this side. Could you need to be tested now if now you are not a known COVID person? And then immediately, some of them will have all this difficulty in breathing. Immediately, they're put on the bed, stretcher there, something is done. If there's a need for even a quick incubation, whilst the person has to be transferred to the main COVID hospital bed, because some of these, they are attached to the main hospitals. So it's part of what we are doing, was instead of just focusing on the Tiger and so forth. That's why you'll find that you go to the retreat, you go to the Victoria Hospital, CHC, you go to the Kraaifontein, you get a different kind of the levels of the tents in order to accommodate as such. In terms of the testing and screening percentage, in the average in South Africa, you find that you will need to, as the data presented to us at a national level, you need to test almost about around 38 people in order to get to a positive person. Now, the question is that how many tests must we do? Because if you look in terms of how many tests we have done vis-a-vis the positivity of the tests, in the Western Cape, we're lucky, shouldn't be lucky actually, that we have got clusters where you could be able to test in, let's say, in one factory of about 300 people, in one supermarket of about 100 or 200 people, where you can test and then you get a lump sum of those kind of results. But what I know for sure, the Western Cape infection and the epidemic and the trends, if you have seen it in the presentation, you'll find that it mirrors differently from what was presented at the national level, where we see a curve going up in terms of the local transmission. So therefore, find that that's why we want to test more, but at the same time, sometimes you want to test in a particular area, and then down the line overnight, you get an outbreak where you get maybe some of the contacts who end up testing positive, and there are quite as many, and therefore you have to go and test them. I think for Member Philander, I think that one is fine, but noting in terms of the burial for the COVID positive persons, it's managed as is with any contagious disease in terms of where you have to meet some of the requirements regarding to how long that the body can be kept, like the body cannot go inside the house and not more than 3 hours or so. And that space you deal with the Department of Local Government and Environmental Affairs, where I know that they've sent all of this to the municipality as the custodians of the grave. It did mention that probably if we end up having many of the deaths, there'll be a time where we have to look in terms of the cremation. In terms of the rural areas containment, the virus, like in the Witzenberg and so forth, again, it started there. I think it is in some of the, not all of the farms and all of those, but to add to what I've indicated in terms of the clusters, we have also developed it's in a draft format now, some of the protocols on how to manage COVID, like in a supermarket as part of the economy space. And also same applies that we're busy now to look into to assist in the farming space. If you have got now 5 and take all of the agri-processing or even in the actual farming, how you'll be able to manage the issue of the COVID in those kind of spaces. And also look in terms of that, how it goes, although for them there might not be much of the high density areas in regard to, in terms of isolating them or taking away from them, but we have to look in terms of the socioeconomic aspects as well. I didn't hear the question about the mask, but the HOD might have heard it. And then lastly, again, the issue of, wasn't sure, remember, in terms of this, I explained the issue of the triage and testing. Again, you will require general beds, which is the hospital beds, which will find that it's more of the majority. And then in the general beds, it's about, in all our hospitals, we do also dedicated COVID beds. Making an example, the last time I was in Tigerberg, they say they've got 320. In addition to that, the triage and testing sites, which is these marquees that I mentioned, which we are planning about 17 of those, some of them you could add field hospital beds. What does it mean? It means that when the people are coming in, and then some of them might just need just a bed, just to put a bed and the oxygen and to be maintained, to stabilize there maybe for a day or so, person can go home without necessarily putting the person in a bed, in a ward. Those ones are already there. We call them field hospital beds. Now, with the modeling, it was found that they will have shortages of those general beds. Hence now the shortages will be met through CTICC, which can give us around about average 700 to 800 sort of the general beds, not necessarily ICU. And then in addition to that, which is I've already indicated, you will need the specific ICU, which is currently there is a shortage of the ICU in the public space. Hence the department has worked with a private hospital to add these beds to become Western Cape beds. For example, in the southern sub-district, we can say, oh, this hospital A, which is a private, plus also our hospitals in that southern, and then it gives us so many beds. So that's what I'm trying to explain. I think I've covered, Chief Whip. HOD, anything else?
Yes, Melissa, I will just add 1 or 2 things. The first one was discussion about Witzenberg and Breda Valley. Just to indicate to Member Philander that what we've learned in Witzenberg and Breda Valley is the cases happen very quickly over a short period of time. And those cases are driven by a specific cluster of cases. And specifically what we do is we go to where the cluster originates and we work with it. And because they happen to be workplaces or places of gathering, it's the generic advice we give. Is to say where people are getting together. Firstly, as the minister said, if you are the positive case, you need to be isolated. If you've been in close contact, you need to be quarantined. Both of those groups of people get taken out. And then we take the close contacts, and if they develop symptoms, we test them. And that's where the new tests have come from. For the workplace itself, where we find this, the issue is then, has there been significant transmission in the workplace? Does it get closed for a short period of time to be cleansed before people go back to work? And that you get people from different shifts or people that's not been in contact with the workers to continue work. So that is the same strategy we use in the metro. That is what we're doing there. In those two towns, Bearded Valley and Ceres, a significant contribution has been from prisons. So it's been prison wardens, and we've been working with correctional services. Specifically, again, now we have to adapt that generic set of recommendations to what you do in prisons. What does social distancing mean? What does it mean? How do you take people off a shift? What do you close? Do you close a wing? Do you clean? All of those kind of things. So it's the generic approach that we're doing for finding clusters and trying to contain, separate, and move people, but then put systems in place that you prevent that from happening in each of those. So like the minister said, we've got guidelines now for supermarkets, but what we've said as a public health intervention in preparation for what happens after lockdown is that we are looking at all the different sectors and we're developing probably quite strict directive. The Premier has asked us to be pretty directive in what we say, of what we think should happen in each sector. And that's why the DG was also talking. Government workers is also a sector. Health facilities are a sector. Police stations are a sector. We need to actually fine-tune our message as a public health message of how do you do prevention in each of those places, so that we can curb the spread in terms of that. Just on the N95 mask, N95 is pretty specialized. There's only one company in this whole country that's registered to be able to do it. You require specific molds and machines to be able to do it. That company is completely overwhelmed by the demand in this country. So most of the N95 in this country is actually from imports. And the people that provides the molds to be able to do the N95, that must still go through SABS in this country and the regulatory body in this country. That the supply of that is way behind, because it's only a few countries that makes those molds. And those countries are overwhelmed by, so it's like the basic mold you must make for a company to meet all the standards to be able to produce N95. Those countries are completely behind because they're supplying the whole of the world in terms of that. It's very similar to what we have with medicine and the raw materials for medicine, which is predominantly in China and India. And this the last one is that the EMS question. The EMS is specifically exposed and vulnerable because EMS must go to somebody's home and go into the communities and get people that might be, and it might not be known to them what's wrong with the person. So we've had to go through 2 iterations, and we're now in our second iteration of protective gear for EMS personnel in being able to protect the crew in terms of what does social distancing mean for the driver, the person that has to look at the person to get them into the ambulance, transporting them. So we put in extra protection for that. But just to end off, we take staffing extremely seriously. And I think everybody has gone into saying, what are we doing about that? And then just for the last member, Heron, just to explain the difference. The isolation and quarantine facilities, we don't recognize those as health facilities. So we make a distinction between isolation and quarantine. And I just want to explain. What you want to do is you want somebody that's positive to be able to isolate. Now, predominantly, you want them to be able to do it in their own home if they have separate rooms. If somebody is a close contact, you want them to quarantine. They don't have COVID, but they've been in contact with somebody with COVID, and precautionary, you move them out of society for 14 days to see whether they develop COVID. Those two things, isolation and quarantine, ideally should be done in somebody's home that has sufficient space to be able to do it. We are coming into dense communities where that's impossible to do. So for that, we are now providing isolation and quarantine facilities. It's not hospital facilities. It is providing accommodation for people where they can be separate from others. And that's where the confusion has come in. People think isolation quarantine is hospital beds. It's not hospital beds. That's why the primary first port of call is the hospitality industry, because of COVID. The hospitality industry has got nobody staying in hotel beds, got nobody staying in guest houses. So the idea is it's actually quite an ideal place to go to ask them to provide separate accommodation for people in dense informal settlements that cannot be separated from one another. What we do and that's why Public Works is managing that for us. They are sourcing accommodation on behalf of people that cannot isolate in their own communities. So when you talk about, we say 8,000 hotel beds, it's not hospital beds. It is hotel rooms and beds. That is what we're talking about. So that number of isolation and quarantine is completely separate from the hospital beds that we're talking about. I think the minister has explained the hospital beds. We talk about acute beds. We talk about ICU beds. And in the acute beds, we're going to make it up with the 1,300 beds that we're planning for to make up for the shortfall of about 1,000. But we're still going to remain with the ICU shortfall of 750 after all of that. I think I'll stop there, Chairperson. Thank you.
Thank you, Dr. Klutty. We still have a number of members that would like to pose questions, but we are fast running out of time. So I'm going to give each member the opportunity to ask their most pressing question, and any other questions thereafter we will put in writing for the various departments. So members, please bear with me, be very brief and pose one question, please. The next is Honourable Nkondlo. Honourable Nkondlo, are you on the line? While she returns.
Can you hear me, Chair?
Thank you. Please proceed.
Well, thank you, Chair. I think most of my questions I'll have to write them up, but I wanted to understand, I think in light of what I think Minister spoke about, the economic sector. So I'm really interested at this point. We've seen the cases of head of cases, and I want specifically to ask whether the department, what has been done with the case of the GSK and the checkers in Table View. Thank you, Chair.
Thank you, Honourable Nkondlo. Honourable Syed.
Thank you very much. I think most of my questions have been covered, but I just wanted to get a sense in terms of the hospitals, what measures are being put in place to assist patients that require chronic medication and that are on chronic treatment, given the backlog that's taking place. And then just in terms of a unified message, I'm very concerned, Premier in particular, when I see MECs tweeting negatively after national government has said something. We understand that there can be critiques and those critiques must be raised, but I just think we need to speak with one voice. We can exercise oversight, but we need to be very mature in the way in which we do it during this period. Thank you.
Honourable Windvogel.
Thank you, Chair. Hello.
Yeah, please proceed.
Yes. Chair, I want to thank the HOD on his quick response last night with the check incident. However, I want to know how many people have been sent to this quarantine site out of the confirmed cases. And then another concern is regarding the safety and security of the testing and screening team on site. I assume that you are aware that they were robbed inside C last week. So my question is then, is there any security measures in place to protect them? Thank you, Chair.
Honourable Christians.
Thank you, Chair. Just the 80,000 positive cases that's expected. I didn't. When is the time period? And I've just heard that the Minister of Coctus said that there might be special provisions for KZN, Gauteng, and the Western Cape because of the spike of cases. So, so I heard the Premier said, or the DG said, 80,000 cases we expect. When is that expected? And is that in 1 week, those cases? And is that the actual peak? And then with mitigation, is that still the figure that we will reach? Thank you, Chair.
Honourable Trejo.
Mine is very short, is on the issue of the facilities for the homeless. If we could be able to get a clear understanding, what is the procedure and the process to be followed in terms of accessing these facilities around the province, because there has been stringent measures that were set up in the city of Cape Town, these ones around the city of Cape Town. Is it applicable to all these facilities around the province, or is it a different approach when it comes to Cape Town? Thank you very much.
Honourable Murray.
Chairman, lady, I will be brief. Would the Department of Health consider, in terms of isolation, to have a contractual agreement with private hospitals so that they can accept trauma patients and those who require to be placed in ICU if they have extra capacity, to free beds in state hospitals if where we need it for the expected increase in COVID cases. Secondly, will they be prepared to engage in the city of Cape Town that the Good Hope Centre also be utilized for that same purpose? It's just a white elephant standing there. Nobody uses it. It can be converted into a place where we can isolate people. And then there's the last question. If hotels make beds available, would you consider giving preference to our medical staff to make use of those hospital accommodation? We cannot afford to lose doctors. We cannot afford to lose nurses. We have already too few of them. Instead of just letting all patients go to hotels, I think the people that deserve top priority should be our nurses, specialists, and doctors. Thank you. That's all I want to say because the others are too long-winded. Thank you.
Honourable Mitchell. Honourable Mitchell. Okay, let's move to Honourable Lecker. Honourable Lecker. She doesn't seem to be on the line anymore. So then the final question, is that Honourable Mitchell?
Yeah, yes, Chair. Sorry, there was something wrong with
your question.
Thank you, Chair. Chair, firstly, let me welcome the presentation by both departments. Chair, I've got one question to the Department of Health, and that's with regards to the two military hospital and what the samenwerking between the two departments is with regards to beds or making beds available and resources available during this time. Thank you, Chair.
Thank you. Then the final question for me is, I note that the projection is that the peak will hit in August of 2020 in the Western Cape. Is there any expectation that there might be more than one peak?
Order, Chair. Order, Chair.
Oh, are you back on the line, Honourable Lecker?
I was on the line actually when you just decided to put on Member Mitchell.
You didn't respond, so I'll give you a chance to ask your one question now.
Thank you, Chair. Actually, I'm going to try and maximize my issues. One question, Chair, is around the issue as to how do the Department of Health identify areas that they may go for screening. I'm asking this because of a concern that I received that in one of my constituencies, an area was identified simply because there's a person who is actually positive, and they wanted to actually share that kind of information with the people. And I think with the latest issue in Kaelicha, where people were toying against the family of the victim, has actually gave us an indication that such operations are actually not proper. Now, the second question, Chair, is actually around the issue of companies who probably have one or two persons identified to be COVID-19 positive, as well as they are a necessary company that needs to operate on a daily basis. And you hear complaints that employees were informed not to say anything about it. They must report back to work. And how do we then deal with that kind of information? Thank you.
Thank you. That then concludes the questions from the members. We are running out of time, so if the responses could be brief, please. I know we all have other meetings to attend. Let's start with the Premier's department.
Okay, thank you very much. I think I'll start with the Honourable Said. You said we're all in this together, and negative tweets, and I would say exactly the same thing to any other opposition member also doing the same thing, and specifically around truth in these tweets. And we really need to work very hard at removing the politics, because politics right up front, and I fully agree with you, politics right up front is not going to help us at all, because it's going to take our eye off the ball. And as has been said, when we reach our peak, I promise you, we are all, every single one of us, going to be, run ragged. We see what happens in other parts of the world, where people are in tears, the officials are doing 48-hour shifts and things like that. And of course, I agree with you. I think the health department will come back on the issue around the peak. The Honourable Klecho, I think specifically, maybe I should just start off with talking about the actual law. This is the actual regulation, substitution of regulation 7 of the regulations. It says suspension of visits. All visits by members. This talks about, remember originally it was like correctional services, detention facilities, holding cells, military detention facilities, but then it was expanded, Department of Social Development facilities, including child and youth care, and suspension of for the period of lockdown, and this from the date of publication. So it speaks to shelters, one-stop centers, treatment centers. And I know that you're referring specifically now to the Strandfontein case. And of course, obviously, I think going to the previous point about how we message, etc. These are big challenges that face us, or face local government, or face national government. And I think the Minister of Health and I agreed that there are serious issues in some of these spaces, and we have to deal with them. What I did do, and I have mentioned it to whoever's asked, and I'm pretty certain, I can check on my email, but I'm pretty certain or my message that I sent it to you as well. I specifically asked Director Roberts in our meeting, how could an opposition member get access, and he said phone them and he will make that access available. But obviously bearing in mind that then you need to do it within those regulation frameworks, because at the same time we also need to make sure that we do have oversight. And then I think the issue around hotels, the department will deal with, but perhaps just to say that nationally they identified 75 facilities. These are stadia, conference centers, big halls, all to be used, including military installations, all to be used. And I saw from the national presentation that's come down to 13 across South Africa. And of course, we are looking at those specific ones here in the province as well. We're playing our part there. I think the rest, the other departments can deal with. DG, I don't know if you have anything to overlay there.
No, I'm fine. Yeah. Department of Health.
Yep.
Can you hear me?
Yes, we can hear you. Yes, we can hear you.
Okay, I will sum up, Chief Whip. I'll only respond to 3 issues. What happens when there's a positive case in a company, like in a supermarket? What happens when there's a positive case in the community? So I'm summing up I'm responding to Member Van Vogel, Member Lekker, and also the Member Kondlo. In this case of a supermarket, you apply the same principle, whether it is been in a prison or wherever. It's about when the positive case, where is the person working? Let's make it, for example, that it's a positive case, who's a cashier, who's at front. Now, the first thing is about the contact tracing, the closer contacts. The closer contacts, what is the definition in that space? It means that the people whom the person is engaging with in less than 1.5 meter distance. And also for when was that? Plus also in terms of that, if it so happened that there might be other people who are not necessarily at the front as cashiers, probably they are the people who are at the back at the stores, where probably the person might have an engagement with that person maybe during lunchtime, and then we have to find out how long was that. Now, what normally happens is about those who tested positive, they will go for the isolation, and then those contact persons who have been determined, has been assessed by our tracer team, contact tracer team, they will communicate with those who need to be quarantined, then they get quarantined. And then the next part of it is about the shop needs to disinfect. There are companies that have been accredited for the disinfection, and also they must close whilst they are disinfecting, and then before they open, they must give us, health department, the certificate in terms of that satisfaction before they open. Some, and also they mustn't use any of the workers who are on isolation or on quarantine. Depending on the size of a company, the others, for example, ShopRite or Checkers or Spar, they could be able to do the disinfection within 1 day, and then they open the next day when we have found that it is satisfactory. Now, what normally happens is that when the other workers find that, oh, Sylvia, who's cashier number 5, is on isolation, and also Jane, who is whatever, is on quarantine, and then they are asking that, and then they are being replaced temporarily by the other staff. Now, that's when now we find that the miscommunication, because we do engage with the store managers or the general management, even at the higher level of those bigger groups. Now, the tension aroused when now people feel that why the others are being replaced through their job without knowing that actually they are going to come back and get the job. In some instances, they'll be asking why the other one is on quarantine and not me. So it's a miscommunication. Now, secondly, you might get cases where you find that there are 1 or 2 of people who are positive, but you might get a case where you find that there's an outbreak, for example, of the Botasser, where there was a quite large number of people, where even if they wanted to open immediately, it was about they couldn't be able to because almost half of their staff were positive. And also it gave them the 5 days. In the case of the GSK, because there are different shifts, if shift 1 does meet with shift 2, it means, and also they're operating in the same space. The company, which is a rich company, wealthy company compared to some of the SMMEs, then they tested all the people. Shift 3 initially has to be assessed first whether they are operating in the same space before. So there's a process that follows that. Now, quickly, in terms of the community, in the community, more or less the similar thing happens is that normal French status positive, the closer contacts is the children, is the people staying in the home. When was the last time you engaged with any other people and how long, when was that? And then it happens. Now, in some cases, the contact tracer team, they deal with the patient and the immediate family of those people. Sometimes the community might have seen that there's a tracer team that entered that house, or because they might not know, especially in the backyard case where they might ask a counselor to assist them to find where is this place. or they might ask whoever in terms of the next of kin, and then end up being known. No, we don't only go for the CST, for the community screening and testing, just for because there's a positive case. One, local transmission should be there, and also there's a vulnerability in terms of the community. Like I have made an example where we find that in some spaces there are backyarders where they are sharing the same F or yard with other homes, and then they are sharing the same space in terms of the toilets and so forth. But there are other cases where we find that actually it's a forum house or it's a council house where we find that the people there, maybe it's a couple and a one child, where they can be able to self-isolate themselves. And also the chances of the widespread of the local transmission is minimal, and therefore rather you prioritize in the areas where there's a vulnerability. So we have got a geomapping that is being done daily, which is active, where you get cases throughout. You can see the bushfires, you can see the flames, you can see there'll be wildfires. That's why in some cases you will say that you're going to go and test, and then the next day we find that we are not there, we have to go elsewhere. Second big, Chief Whip, again, the modeling the Premier mentioned in terms of the August, because we have to move with it according to the data. Initially, it was about around the June, and then it keeps on moving right about August and September. We might have that peak. In terms of, I think the question that was asked by a member, Christians, about what is this spike, this 80,000? It's about the time where you might have end up having, like today, you might have 1,066 and 68 cases. But there will be a day where we find that when we count from when we started, and then find that we have got that highest peak. Again, it's based on the modeling. There are many other factors that might change, but based on what we have in regard to how many cases do we get. If you get 100 cases per day, which is what has happened now, it might lead us to that. And also the climate and the weather and other factors. If our winters could be quite severe up to that, those who have compromised immunity, they might end up having the comorbidities and all of those. The same as that, if the older persons who are also have got the issue of the immunity, we might get up to that level, or we might not know. And then there's a debate about whether there will be a second wave of the COVID. We don't know at this stage. I think HOD, you can respond to the other issues. Thank you.
Thank you, Chairperson. Very quickly, I'll go very quickly. The peak of 80,000, Minister has gone there. It is aimed for August. That's based on evidence at the moment, and the evidence suggests that, and that's the 80,000 positive cases at the peak. If anything changes, it could be earlier, it could be later. You'll see as data unfolds, and we update from a week-to-week basis. In terms of a second peak, it is likely until you have a vaccine that there will be other peaks. But the important one is the initial peak, because the initial peak is the one that's going to stretch your capability. The other peaks are likely to be smaller peaks, and you will be able to cope with those. The issue of the military, yes, we're working with the military, and we're maximizing and incorporating their working with us. The issue with chronic beds, we have a system in the metro where chronic beds are delivered to individual patients' home. It's a contract with Uber and with community health workers, and we've been able to do it quite successfully over the last 2 weeks. We are working with the private sector. We're working jointly with them. Our understanding is that the acute beds and the ICU beds are being used as a combined platform. So therefore, we are maximizing partnership to maximize work with hospital beds between us and private sector. The issue with the city, we are working with the city, and specifically we are getting a commitment to get the convention center, and we will be moving from that perspective. The issue of communities screening and testing, the teams are more and more being threatened by violence, and it is a concern to us. And we have made an appeal today that we have full-time presence in high-risk areas for the teams to be accompanied. The issue about how we decide to do community screening and testing, the point we'll be using is we're combining community screening and testing with hotspot identification and cluster identification. So we deliberately are saying where we know there are cases of local transmission, We want to go to neighboring streets, households, to be able to find people that might be infected so that we can contain the spread. So that is our deliberate strategy. And then the last issue is the hotels that are available for quarantine and isolation. It's the same hotels and guest houses that we are working on a system that when required, we will be able to offer our staff to have accommodation there without traveling home. Thank you.
Thank you, Dr. Kliti. That then concludes the questions, and I'd like to thank the officials from the government departments, from both the Department of the Premier and the Department of Health, for having briefed us today. And we'd like to express our heartfelt and most sincere gratitude, not only for the time that you spent with us in this meeting, but also the great strides that you and your colleagues are taking every day. We're sure that you're taking personal and professional strain as you work around the clock every day, and you're making many sacrifices, including time with your families and your loved ones. I think we can all agree that you're at the coalface of this crisis, helping to guide and keep us safe during what will go down in history as one of the greatest challenges of our time. So thank you very much for your efforts. There is no guidebook for the pandemic that we're facing, but I do believe that we find ourselves in very capable and very caring hands. So I want to thank you on behalf of the committee and encourage you for the very incredible measures that you're taking for the people of this province. And please know that we are here to support you every step of the way. Thank you very much. I will then excuse the departments and ask the members to stay behind for some committee deliberations.
Thank you, members.
Thank you very much. Thank you, Chief Whip. Thank you, members. Thank you. Signing off.
All right, members, I am aware that there are other meetings taking place now, so if we could try and conduct our business as briefly as possible to conclude this meeting. I will ask then that if there are any recommendations or resolutions, that those be sent to me in writing by noon tomorrow. Similarly, if you have any questions that were not answered or you are not able to ask in the meeting, please also send those to me in writing, and we will include that in our correspondence with the departments so that you can get some information to those questions. Then I'm assuming that you've all read the minutes of our meeting of last Friday. Can we move to adopt them?
I move that we adopt, Chief Whip.
Thank you, Honourable Mitchell.
I will second.
Thank you. Who was that?
Regan Allen.
Oh, thank you, Honourable Allen. Appreciate it. Then for Friday, we had originally scheduled the meeting for 9 to 12. Unfortunately, there is a clash with the cabinet meeting, so our ad hoc committee meeting will take place then from 2 till 5 on Friday on the theme of food security. We will then circulate the program for next week. I just wanted to test with members then next week, Friday is a public holiday, being the 1st of May. We did agree that this committee would meet twice a week. So can we then meet on Wednesday and Thursday, or would you prefer to meet just once next week?
Chairperson, we can meet
Honourable
with
Bartman.
Chairperson, I would like to suggest that we do meet on the Thursday as well then, or on the Wednesday as well then.
Thank you. All right. Okay.
Honourable Mackenzie here. Can you tell us what was the two issues for next week that we were going to discuss anyway?
Okay. The two issues will be policing and protection of the vulnerable.
Well, based on that, then I would suggest that we go with Honourable Bartman's suggestion that we do both days, because it's two very important issues.
Fair enough.
Agree.
Okay.
And we not spread it.
Okay, one at a time. If you'd like to speak, please put your name in the chat bar. Honourable Maria, please proceed.
Thank you. If we are going to have 4 or 5 DA members speaking first and taking up 3/4 of the time, then these meetings are going to become cumbersome and wasteful. I must object to that. It's not fair then this meetings could have been conducted in the DA caucus. We don't have to have an ad hoc committee.
Honourable
We should
Murray,
have
I'm
one
going to call
of
you to
each
order
party
immediately.
alternately.
On a point of order, Chair.
Calling you to order, Honourable Murray. It was decided at the beginning of the meeting that if you wanted to pose a question, you were to write your name in the chat bar. The fact that you didn't write your name in the chat bar until the meeting was well advanced is not in any way a reflection on the DA, but rather a reflection on you. And in fact, all of those members were recognized in the order that they wrote their names in the chat box. So I'm not going to take that point. Is there anything else anybody would like to add? Honourable Nkondlo, I recognize you.
Yes, thank you, Chair. Can I request that, I'm not sure which week, that we also bring the discussion on the economic response, because I would think that we always need to strike a balance on this conversation so that as we prioritize social related matters, there is an equal balance with the economic issues, because on the ground, part of the pressure is the fact that people are unable to earn their livelihoods. So I just want you, Chair, in terms of how we manage the agendas of the committee, that we try and fuse in that balance so that we don't have to wait long. I support that we will have to write some of the questions that we could not, and maybe with our team of IT, I think somehow we'll need them to maybe behind the scenes check what are some of the biggest issues around connectivity that are actually disrupting us as we're engaging. Because I think on one hand, I feel the meetings are taking very long, and because of that, they take data, which is one thing I experienced today. But also, I think we need to find a way, given these virtual meetings, how do we ensure, indeed, as Honourable Murray is raising, how do we ensure equitable participation of members? Because it can be long, and sometimes you end up only few people speaking. So I will leave that to yourself as the chair on how can these meetings be managed in a way that there's maximum participation of everybody. Thank you, Chair.
Thank you, Honourable Nkondlo. We will then make the economic recovery move it up as a priority. So we could perhaps look at that not next week, but the first meeting thereafter. We're happy to do that because it's also an issue that is very pressing and something we would like to delve into. We did agree at the beginning of the meeting that whoever wanted to speak could write in the chat bar that they wanted to be recognized, and we followed that process and procedure, and it was done absolutely according to the order in which members wrote their names in the chat bar. I think for the IT things, we will do a post-mortem with the procedural officers and the team to see how we can iron out some of these teething problems. And I'm quite confident that as we have more of these meetings and we're more and more familiar with the system, they will run smoother and smoother each time. Okay, so then we agree that any questions that members have for the two departments, i.e. Health and Premier, please could you send those to me in writing or to the procedural officers in writing by noon tomorrow, as well as any recommendations and actions. We will then deal with those at our meeting on Friday during our admin time.
Chairperson, may I just raise a question?
That Honourable Heron, please proceed.
When we first met, we were to submit a whole lot of issues and questions that would be addressed in the presentation, but I feel like that was a bit of a waste of time because I submitted some very detailed issues which were not really covered. So I mean, is this the way we're going to proceed, or is this just because this first presentation was so close to when we had our first meeting?
So what I did is I took all of those issues that members raised and summarized them, because some members, there was quite a lot of overlap in some respects. So I took the major issues that members had raised, and then in a follow-up letter to the two departments, we asked that their presentations cover those issues and questions that the members had raised. However, there was a very short space of time between that and the presentation, so I think it is largely a function of that. The same has happened with the Departments of Social Development, Agriculture and SASSA. Based on the members' inputs, we've submitted additional correspondence to ask them to cover it in the presentation. But more than that, I can't really control what is contained in their presentation. So we hope to have more time for engagement. So if those issues are not covered in the presentation, you have the opportunity to ask it after the presentation.
Chair, can I come in, please?
Is that Honourable Syed?
Yes, Chair, it's Honourable Syed. Chair, it's on the point raised by Member Heron about the issues sent. Can I perhaps propose, Chair, that as we are now talking about topics for the next meetings, can we get a draft program probably sent to us tomorrow or so, or even on Friday, once we have concluded that meeting of Friday, maybe over the weekend, a draft program of the committee for the next few weeks, and that can then speak to the themes and the issues that we submitted as members. Because I also would like to see the Minister for Local Government to also come here to speak about what our municipality is doing, for example, and there's various other issues, education. So if we could perhaps get a draft program with the dates of the meetings, the times and the topics, and who we are going to be inviting, and then members can then comment on that possibly over the weekend. Chair, thank you.
Yes, absolutely. One is in progress at the moment. We were waiting for the inputs of the members in order to conclude the program so that the program can be more detailed in which departments we're going to call under each theme. And I want to thank members for their very many varied inputs that they gave for all the themes. It was really very heartening to see such active participation across party lines. So thank you very much for that. So we hope to have that ready for discussion at Friday's meeting during our admin time.
Chair?
I don't know who's speaking.
It's Member Dagmore.
Okay, Honourable Dagmore, please proceed.
Yeah. Thank you very much, Chair. I would like to move as a resolution for this committee that the committee also expresses its support.
Honourable Dagmore, we're going to put resolutions in writing, and then we will discuss that at the next meeting.
Okay, sorry. Now I understand what you were saying.
Thank you. Anything else?
Chairperson, Ricardo Mackenzie.
Honourable Mackenzie. Yeah.
Sorry, Chairperson.
And I also thought
you didn't look at the chat box for the last while. There are quite a few members have indicated they wanted to speak. Way before I spoke, I just saw and I alert you to that. There was quite a few members put their names in the chat box the last 20 minutes, but obviously you didn't look at it the last one.
No one's. Okay. All right. Honourable Syed has spoken. Honourable Dagmore spoken. Honourable Nkondlo spoken. Honourable Mitchell, you next. I'm trying to do this in an orderly way.
I'm covered, Chair. Thank you.
Okay. All right.
Is it my turn now? Is that my turn?
I didn't see a request from you, but please proceed.
Chair lady, I want to ask you, and I really am serious. I'm a person who likes to give solutions and offer solutions rather than get entangled in broils over Skype. But you can limit the number of questions to 2 maximum, and then give them a second bite at the cherry, and then stop officials to answer a question taking up half the meeting's time, mumbling answers which already was in their presentation, and they repeat those facts and they repeat those stats which we saw in their presentation. How is that conducive to good oversight? I mean, oversight means the opposition watch the rulers. Here the DA want to watch themselves. They speak the most. I object. And I want to say, although I'm a small party.
I'm a full member, Chair. Chair.
And this is now
Chair, can I come in, Chair?
Interrupting.
I think there was a point of order from Honourable Mitchell.
And you allow it. You allow Mitchell to interrupt while I'm speaking. He
he's
is still
raising a
learning
point
to
of
be a
order.
deputy whip.
On a point of order, Chair, I think the Honourable Marais is it's unfair, and it's now going into casting aspersions on individuals and on you as the Chair. I think if Honourable Marais would like to propose meeting procedures, he can do so offline to you, and the two of you can have that discussion offline.
Okay. Thank you, Honourable
I
Marais.
think you
Can we
don't
take
need
this
to be
offline
part
and
of
I'll have a
Mr.
conversation with
Mitchell
you?
much longer than you in this game.
I'm glad that you think that this is a game. To me, it's not a game.
Chair, can you take control of the meeting, please, Chair? There should not be dialogue between members, Chair.
Thank you, Honourable Syed. I think on that note, we have made the necessary agreements, and I'm going to then conclude the meeting, and we will see you all on Friday at 2 p.m. Thank you very much. The meeting is adjourned.
Thank you, Chair.
Thank you, Chair. Thank you, Chair.
Thank you, Chair.
Thank you,
Maybe
Chair.
Maybe
Thank
we
you,
can
Member
elect
Dr.
a deputy chair. Maybe we